mental health. I would like to thank Senator Brooke for her work in helping to convene this virtual public hearing on mental health crisis services. I would like also to acknowledge my colleagues in the Assembly who are here today, which include Assemblyman Gandolfo, Assembly Minority Ranker for Mental Health, Assemblyman Harry Brunson. We also have, I'm looking right here, I have Doc, Assemblywoman Judy Griffin. I think that's all I have at this point, and I'll have to, and I know I see Assemblywoman Missy Miller. So later on, we'll introduce the rest of them. I'm grateful to those who are testifying today. It is my hope that with your help, we can work towards improving the mental health service delivery system. And we use today as a platform to exchange ideas and come up with ways to transform the way we provide mental health care. Senator, you have an opening statement?
Thank you, Chairwoman. Quick check, are we already live or are we doing this all beforehand?
We're live.
We are live.
Great.
We are live.
Didn't realize that. Thank you so much, Chairwoman. Again, I'm Samra Brooke, the chair of the Senate Committee on Mental Health. I'd like to acknowledge some of my colleagues who are here. We do have our ranking member, Senator Tedisco, along with Senator Harckham, May, and Brisport. So thank you all for joining us in this important conversation. I want to just quickly open with the fact that while I'm proud to be the chair of the Senate Committee on Mental Health, I'm also the state senator representing the 55th Senate District over with parts of the city of Rochester in my hometown, and I'm a Rochester resident myself. And being a Rochester resident and representing that community means that I come into a conversation like today and a hearing like today, still with a heavy heart for a lot of the lives that we have lost, because as a state and as a country, we have yet to figure out how to effectively and compassionately handle folks who are in a mental health crisis. And we still are looking for justice for Daniel Prude, Tyshawn Jones, two men who lost their lives here in our community, and a 9-year-old girl who was pepper sprayed while calling out for her father during a crisis that she had in her own family. And we know that this is part of a crisis that's much larger. There is a mental health crisis in our state. And so we need to take steps to figure out who shows up in a crisis moment. How do we approach these types of crises? And really, more than anything, I think we have an opportunity here in New York State to really change the script, to change the paradigm around how we think about mental health and mental health crisis. We can reimagine how we address this mental health. We can make investments, and we can follow the experts, many of whom are joining us today. And let's remember that with these changes comes saving lives. So I very much look forward to the conversation. Thank you to everyone who is taking the time to share your expertise and your experiences with us today. And I look forward to the conversation.
I also wanted to mention who the Assembly members are present. Assemblyperson Gandolfo, Assemblyperson Bronson, Assemblyperson Griffin, Assemblyperson Santa Barbara, Assemblyperson Miller, and Assemblyperson Griffin. So thank you. So I guess we should begin, Senator. I don't know if you want to take the lead. We have Dr. Ann Sullivan here today, and we're excited to hear from you, Dr. Sullivan. So if you would begin.
Thank you. Thank you, Senator Brooke, Assemblywoman Gunther, and members of the Senate and Assembly Mental Health Committees. I want to thank you for the invitation to address you today in relation to New York's mental health crisis service delivery system. A comprehensive mental health crisis system is the linchpin to an effective New York State mental health system of care. The Office of Mental Health is making substantial investment in New York's crisis response system to expand our capacity, timely response, and critical services. The expansion will enable individuals experiencing a mental health crisis to receive timely services and provide care safely in the community, reduce unnecessary emergency room visits and hospitalizations, and significantly decrease the need for law enforcement intervention and reduce the risk of future crises. This requires intensive coordination and information sharing among recipients, healthcare providers, law enforcement, criminal justice, community providers, and organizations to reflect the recipient's goals towards recovery. The community-wide commitment and involvement is critical, and these services need to be delivered in a trauma-informed, recovery-oriented, and culturally and linguistic competent way. To realize this redesign, New York is prioritizing prevention across the lifespan and investing in programs that support early identification and intervention, including first episode psychosis. We have learned from this pandemic and our implementation of New York Project Hope the importance of immediately available crisis counseling and emotional support. We have learned from the 80,000 callers, many of whom have never contacted mental health services before, the need for a responsive service that requires prevention and support for individuals as well as community-wide crises. Prioritizing prevention for children, youth, and families due to the traumatic impact of COVID, including school-based services, home and community-based services, and crisis interventions. These services must be designed to meet the needs of our most vulnerable communities. Developing robust crisis community services, including a comprehensive and coordinated response system, which integrates mental health and substance use treatment and addresses the emergent and immediate needs of New Yorkers of all ages and connects them to the wider mental health system. As the pandemic is hopefully subsiding, we are seeing the expected increase in need for mental health services. And while crisis care is step one, ongoing care and services must also be readily available. Addressing the intersection of the criminal justice system and behavioral health systems by connecting individuals in crisis care through teams of trained mental health professionals, through the training of law enforcement by advancing innovative criminal justice system diversion programs, and serving and supporting individuals exiting incarceration. A major goal is to have the vast majority of mental health crises treated by mental health professionals without any need for law enforcement intervention. Transforming New York's mental health system to advance a culturally competent, social equity-driven network of recovery-oriented treatment and support services that meet children, adults, and families when, where, and how they need it most. Special priority will be given to the most vulnerable and underserved communities. Implementing specific strategies on payment parity and provider sustainability needed to reduce disparities in access and treatment outcomes in communities across New York State. Crisis services are traditionally financed primarily by Medicaid and state funding. It is critical that Medicare and commercial payers share the cost of these services, which are as critical as medical care provided in urgent centers across the state. Federal funding will enable New York State to address startup costs associated with this system redesign. OMH received a federal Community Mental Health Services Block Grant supplemental award of $46 million for the period March 2021 through 2023 as part of the Federal Coronavirus Response and Relief Act. OMH will be dedicating significant resources to develop crisis infrastructure, including the 988 crisis response system, crisis services, ambulatory redesign, law enforcement training and diversion services, prison reentry programming, first episode psychosis, and children, youth, and family services. We also anticipate an additional award coming probably in September through September 2025. OMH will be dedicating significant resources from this award to support startup costs and the development of capacity to address any gaps in the community mental health system. So what are the elements of a comprehensive crisis response system? First, the system includes someone to call when you're in crisis. Secondly, someone to come and meet the individual in the crisis right away if needed. And then a place to go when experiencing emotional distress where you can receive timely assessment and treatment. The elements of the system include telephonic triage and support, mobile crisis and follow-up services, crisis stabilization centers, crisis residential programs, comprehensive psychiatric emergency programs, and access to community-based treatment and services. All of these are coordinated with ongoing community services. OMH continues to have conversations with the public at large, stakeholders that include local government units, community advocates, consumers, providers, and first responders to design the system and determine gaps and opportunities for crisis development. I will now describe a few key pieces in a bit more detail. Crisis stabilization centers. I want to thank you for supporting and including in the recently enacted 2021 budget authorization for crisis stabilization centers. They will provide immediate engagement, assessment, treatment, and referral services for mental health and substance use problems at any time of the day or night. The direct and immediate access to care will be available to individuals, families, and youth avoid unnecessary hospitalizations, manage assessment and treatment of mental health and substance use disorders. OMH and OASIS are in the process of developing the regulations and program guidelines to provide fully integrated care. Crisis stabilization centers admissions are voluntary, will provide walk-in urgent services, and will operate 24/7, 365. They will coordinate with local providers of care, law enforcement, community treatment, and support services. Under discussion with stakeholders is a flexible tiered approach to these services, depending on community services available. So there's a full range of crisis centers that have already been piloted across the state can continue and grow depending upon community need. Medicaid and commercial insurance coverage for services provided by these centers is required. Also, the mental hygiene law was amended to authorize the diversion of individuals experiencing a mental health crisis to stabilization centers instead of hospital emergency departments, if someone voluntarily agrees. This will enable individuals and families to receive care in warm and a welcoming environment and provide trauma-informed and recovery-focused services. Crisis stabilization centers need to be intimately connected to crisis residence system that offers the opportunity for short-term stays in a therapeutic residential setting, enabling individuals facing a mental health crisis to return to their community and avoid the need for psychiatric hospitalization or emergency room use. Crisis residence programs provide a safe, supportive place for individuals in the community while they address and resolve their crisis. OMH has updated the crisis residential regulations, allowing for expansion of reimbursement through Medicaid. In addition, $50 million for capital development was awarded to provided across New York State for expansion of crisis residential programs. This funding will support an initial 33 programs, including 20 adult and 13 children's programs. Peer-run crisis residences have been shown to provide diversion from higher levels of care and provide connections to community resources. A critical first step is an accessible, reliable telephone call system that connects the person in crisis to a counselor and services as needed. In October 2020, the National Suicide Hotline Act established the 988 crisis line for immediate access to the suicide prevention line, connecting callers in need to local services, including mental health, substance use, and community services. The Lifeline will provide emotional support, information, and resources to callers looking for immediate assistance to mental health crisis and suicide prevention. 988 can now serve as a single point of easy access for support and connection to crisis services and will be accessible to all New Yorkers by July 17, 2022. Vibrant Emotional Health, the administrator of the Lifeline, has provided New York a planning grant for the implementation of 988. OMH is meeting with a statewide coalition of stakeholders to develop a roadmap for coordination, capacity funding, and communication strategies, including a landscape analysis of need for the most vulnerable communities. The implementation plan is due for review and approval by December 31st, 2021. Another key component is the availability of a timely mobile capacity to meet the person where they are in the community and begin the process of crisis resolution with trained mental health professionals. In New York State, 50 out of 62 counties have access to some type of mobile crisis service. A mobile crisis team of professionals assesses immediate crisis, facilitates resolution, identifies the individual's concerns and needs, partners with the individual to connect to ongoing supports, and works with them to make sure those connections are made. At times, if the crisis is severe, the mobile team could work with the individual to receive urgent care at the next level of service, such as a crisis stabilization center. OMH required county mental hygiene directors to create initial mobile crisis response plans for adults and youth and to identify providers eligible for reimbursement through Medicaid managed care. This planning lays the groundwork for future mobile crisis planning and for coordination and telephonic triage services. In conjunction with crisis response and stabilization development, OMH plans to use funding for the systematic preparations necessary to divert individuals in crisis from law enforcement and criminal justice settings to mental health services, including training and equipping law enforcement with the skills and tools necessary for de-escalation and diversion. Training, intercept mapping, diversion support are provided in collaboration with county mental health departments and law enforcement and the criminal justice system. Also, the community approaches that include mental health professionals responding with law enforcement when needed are being examined and piloted. Summary: Finally, it is important to remember that a crisis system of care can only be effective with the ongoing support and involvement of all members of the community, including health and behavioral health care providers, community and faith leaders and organizations, schools, law enforcement, and criminal justice, families and clients who partner with us in care. Again, thank you for your interest and support for the New York Crisis Response Delivery System. I'm looking forward to addressing any questions. Thank you. I think,
Senator, do you want to go first, or do you want
Sure.
me to go first?
I can go first.
Okay, go ahead.
Thank you so much, Commissioner. I appreciate being able to hear from you as always. I want to start with one of the last things that you talked about in terms of having this crisis line that anyone can call, the 988. And you talked about speaking with folks from around the state of figuring out what this looks like and talking to experts and advocates and providers. And you mentioned that there is a planning grant that has come in to the state for use of the 988 system of establishing that. Can you give us a sense of how much funding you anticipate needing to establish the 988 system?
well, I'm not sure about the total. The planning grant itself is about a little bit over $300,000. We're in the process of trying to determine what the cost of the 988 system will be. It depends to some extent on how it's designed. So I can't give you a number that would be, I don't want to give you a number, but it's in the millions of dollars. It's not something which doesn't cost a fair amount of money, but it will depend on how the linkages are made to local providers, local connections. And so we're in the process of getting that number, and hopefully it won't be much longer, because that's part of the planning grant, is to come up with a number of basically what the system will cost.
And did you say, I think you mentioned a date, September 2021. Is that the date that you anticipate having used the planning grant to come up with the
Hey,
official?
Matt, could I be a
No,
pain?
the date is the actual planning grant has to be completed by December of this year. September is the date we're anticipating additional dollars, possibly from the feds, for the mental health block grant. We may be able to see additional dollars, which will also help support the system. But December 21st is the date we have to have the planning grant completed and into SAMHSA and Vibrant, who gave us the grant. Vibrant runs the Lifeline, Suicide Lifeline.
Great. Thank you. And my other question about 988 again is, have you considered, and could you offer what types of safeguards might be needed to make sure that any funding that comes in for 988 is only used for those services, whether it's the startup or the ongoing services, and not for any other purposes?
There will be certainly there will be very strict controls on the use of the dollars. Let me just say this: that the mental health block grants which are coming forward, which are doing the startup, are very carefully looked at by SAMHSA and the federal government, as well as our division of budget, to make sure that all those funds are appropriately used. And we have to report to the federal government on anything in the mental health block grant. When it comes to the dollars that will be appropriated in whatever form, and it's not clear yet exactly how those dollars will be raised for the ongoing 988, that will also be monitored very closely internally by the Division of Budget and others in the state, as well as the Office of Mental Health. And those dollars will have to be earmarked for 988. That's the only way that it can be a successful system. It has to have earmarked money that is there every year.
Thank you. That's all I've got. Thank you, Chairwoman.
Good morning, Dr. Sullivan. How are you?
Hi.
So I have a few questions, but I'm going to start with something that happened with the senator and I. So we had an incident outside the Capitol about 2 to 3 weeks ago with a woman that I know very, very well. And her history is severe abuse, being in jail, so many terrible, terrible things. And so she's near and dear to my heart, and Tom Gatto, who I work with, and we have somewhat of a trust. So to make a long story short, and not going back in what I know and what I don't know, she was having an episode. And the episode was this person has had extreme abuse over her lifetime. And so we thought, wow, we'll call for emergency help. The closest mobile crisis center, and the senator was there, was 50 minutes away. 50 minutes away. And so, what happens to people like my friend that was in crisis is that often what happens is that my dad was a police person, and I respect every person that is in the police field, but they don't have what is necessary to be able to calm the situation down and provide the care that's needed. This happened to us, the center. We stopped what we were doing. We ended everything because we didn't want her to like rev out of control and have her arrested again. So I just want that to be on your minds when we talk about Mobile Crisis Center, which we've talked about for a very, very, very long time. And it's very nice. And Anne, this has nothing to do with you, but we, there's an old saying, talk the talk, but we got to walk the walk. And now more than ever, with this pandemic, we are learning that we haven't walked the walk. I see that we're getting $46 million. You know what? How is it going to be used? How can we streamline getting this money from pillar to post so that we're actually in the communities, many communities now, whether they're rural or in the Bronx, we know that people are suffering and the money is not getting there. And I think that this cannot be developed, and I'm gonna say it, developed from up here. It's got to be from down in the streets where people know what's going on, where it's going on, how it's going on, and the needs of the people that they served. And you know what? We closed a bunch of psychiatric beds this year. I was completely opposed to it. We need those beds to be able to deal with people in crisis, not to send them to jail. And this is nothing against police, but not to send them to jail, but to be able to medicate them and watch and observe their reaction to the medication. Is it helping? Is it not? An emergency room is not the place. And yet, there we go. We close those beds and act like that they're not really needed. We don't want to treat people in a crisis situation, but we have to. And you know what? By putting them in an emergency room and putting them out, and there's not enough people on the street, we haven't invested enough. So at that note, you can see I'm upset, and I know a senator is also, but you know what? I feel like I have this role, and I have to make sure I am fulfilling my responsibility to all of these people. So can you now provide me with the latest at a later date with a breakdown of how many mobile crisis teams we have in New York State, where they are located, and also the different crisis services we have across the state? And is New York State planning to expand? You said, yes, we are, with the federal dollars. So that's my first question. I have a few more. And I'm sorry, this is not being upset at you, Dr. Sullivan. I am upset at New York State and the system.
Yeah, well, thank you, Assemblywoman, and truly, you're making some very good points. So let me talk to them a little bit. First of all, in terms of the crisis, I can get you all that information. Right now, approximately 50 of our counties have some degree of mobile crisis availability, but it varies, and the response time varies. And your point initially about how long it can take is one of the major investments that we're going to have to make with the dollars from the federal government.
Are you going to make that decision from the top down or the bottom up?
No, there's going to be a whole level of intervention. The local government units have been working with us all along. This is going to be done with the local government units and the providers on the ground. Each county has a different setup and availability of services, so it has to be tailored to what's there ultimately. What we will be doing is probably working, it's going to have to be phased in across the state to get the kind of response time you want, which is much more rapid than an hour. So if we want to get that, we're going to have to phase it in. We will be working with specific counties, but we'll eventually, our hope is to be able to spread it across the entire system of care. That 46 million except 25% will go for children's services. Otherwise, it's essentially going for crisis. 25% of children's services, 10% mandated by the feds for first episode psychosis. The rest of the dollars are going to the crisis development, which is going to include the startup to do exactly what you're talking about.
Here?
Get enough crisis services out there that
Oh,
can be
Christ.
easily, that there can be a
Matt,
better response time.
Something happened.
Whoops. Okay, so that's a major piece of the planning. The planning will be done across the state. And I think that we're doing it, yes, with stakeholders, with consumers, with everybody from the bottom up, as you said. It's not something that you can just do from the top down. Those dollars will also help with probably with the startup of 988, but the ultimate funding of 988 is going to have to come from a different source, and that's going to have to be in place. We've been working very hard to get crisis services all reimbursed by Medicaid. And as I said before, we also need help getting commercial payers to pay for crisis services, et cetera, so that we can do the kind of expansion you're talking about in terms of having those services available in a very timely way. The 988 number is only going to work if you can get a really rapid response. And we only have a few places in the state that are capable of doing that 24/7. So we really need these dollars to expand those kinds of services and then get them reimbursed through the payers.
I would hope that you would involve the senator and myself in these decision makings, because I am on the ground every day. You know, as a nurse, I volunteer at the hospital, so I see a lot of what's going on. And I think that, you know, that there should be a community meeting in each county so that we can get all of the players together, so that it's not done, you know, from the top down again. And often, you know, those people that are, you know, in the trenches know where they need the help the most, what neighborhood, what area, how to get there. So I think that's important. Can you explain to me the difference between mobile crisis teams we have in New York and the CAHOOTS model? What is the difference in staffing needs?
Well, we're again, that's why you need to develop it from the bottom up into what's going to work in each county. The CAHOOTS model is one model, which is basically a nurse or an EMT with a social worker who goes out and responds, or another mental health professional who goes out and responds. There are other models. Sometimes some models across the state will have two social workers who will go out with the backup of a psychiatrist. Other models will have a nurse and a social worker go out. Other models are more tightly linked with the police. That's something we'd like to kind of, well, not necessarily foster as much, although police need to be trained because they will still get some 911 calls, and we need to work with them. So, but yes, there can be different models, and it depends on what's already in a county and also what a county is capable of providing. Some of our bigger challenges are in the rural counties, where just the ability to move, as you say, response time, to be able to drive to a crisis can take longer than we would want. So that one of the challenges, many of those counties that don't have a system are in the more rural areas. That's a real challenge. It's something we're looking at models across the country of how you deal with that in terms of an in-person.
It's only a challenge if you don't have money. We have hospitals, we have clinics, and all it. A lot of it is the investment of New York State. Do they want to invest on the beginning or the end? More expensive is getting people hospitalized. Less expensive is putting the down payment on mental health, and it really is, and keeping beds open when crisis happens, which we are not doing at this point. According to SAMHSA best practice guidelines to operate mobile crisis teams, you need to do the following: incorporate peers within the mobile crisis team, respond without law enforcement accompaniment unless special circumstances warrant, implement real-time GPS technology in partnership with the region's crisis call center, and schedule outpatient follow-up appointments in a manner synonymous with the warm handoff in order to support connections to ongoing care. Does New York follow these guidelines? And if not, is there a plan to implement them?
Most of the teams do follow those guidelines to some extent. We're going to be those will be implemented across the state. Yes, we don't have peers yet on every mobile crisis team in the state. Some teams do have peers. Definitely follow-up is followed by everyone. And having professionals going out and responding, that's all our mobile crisis teams. The peer part.
Okay, I'm out of time. They just texted me. I'm out of time.
Oh, okay.
Sorry, Senator. Sorry, Senator.
It's okay. I think we've got some questions from other folks who are on the call with us. So I see a raised hand from Assembly Member Harry Bronson.
Thank you, Chair Gunther and Chair Brook, for having this public hearing. It's very important that we have this conversation. And Commissioner Dr. Sullivan, I want to thank you for being here today. And I also want to take this opportunity to thank you for being so responsive when I've called you in connection with constituent issues and also in connection with the Rochester Psych Center. It's been a while since we've spoken, but when I've called you, you've been there. So thank you, thank you, thank you. You know, throughout this country, in New York State and in my hometown of Rochester, it's clear we need drastic, transformative, systemic changes in our mental health crisis response. Joe Prude, brother of Daniel Prude, has been leading the charge of this change so no other family will have to endure the loss of a loved one when their call is for help. I've met with the advocates in Rochester, and we've developed legislation in the name of Daniel's Law. And it establishes a state and a regional mental health response councils that would require mental health professionals to respond to mental health and substance abuse emergencies. And I'm glad that Chair Brook is taking that charge on this legislation in the Senate. Daniel's Law is a comprehensive, culturally competent, and thorough legislation that promotes the public health safety and welfare of all people in New York. The legislation, in essence, moves us from a response of control and force to a response of compassion, care, and consent, voluntary treatment. My question for you is, what's happening currently in the state to make sure that our crisis responses are dedicated to the goals of de-escalation, culturally competent, and will avoid contacts with the criminal justice system and be trauma informed? What steps are we taking currently in that direction?
We work, we have centrally in OMH, and then in each of the counties, we have staff who work on the training, the development of the crisis teams that are there at this current time, and make sure that they are providing the kinds of services we want, which are very much in line with everything you said, Assemblyman Bronson. I mean, it has to be compassionate care, it has to be outreach, it has to be focused on mental health, using law enforcement as little as possible at all. All those principles are embedded in the training and the design of the current mobile crisis team. But to some extent, I have to let you know that they can't respond as quickly often as we would like. And that's where a lot of the dollars will be going in terms of expansion and ensuring that individuals are available to give those services more rapidly on a regular basis. Some of our teams are not open yet 24/7. And so that would be part of the expansion. But the basic principles of compassionate, trauma-informed care are things that we train people in, and then we monitor that that's what's happening with the crisis team.
Okay, thank you. Just if I could ask one more question. So in Daniel's Law, we set up a mechanism where there would be a statewide council, and then recognizing, and a point you made, that we need to tap into the assets that exist in regions across the state and figure out what their demands and what their needs are across the state. So we need regional input. So it's a mechanism of creating broad statewide parameters with regions being able to fit their systems within that broad statewide parameters, and requiring that those councils are, that they have mental health professionals involved in those counselors, including peer counselors. What can we do using that kind of a model? I think is allowing, I think Chair Gunther mentioned this about, having folks in the field and have a bottom-up approach. So you kind of have two. You set standards at the state level, but you have a bottom-up approach where regions are making the detailed decisions they need, and that only mental health crisis teams that are certified would be able to respond to this. Do you have any general thoughts about using that kind of an approach as we develop these mobile crisis teams and the mental health crisis teams that need to be responding in a compassionate, caring way?
I think that, certainly the point of having a regional approach is very important. And the planning that we're doing with the planning grant for mobile crisis is regional. It doesn't make any sense to not do that. I mean, you really have to kind of use the resources that are available throughout a region. Just like healthcare, general healthcare is also often planned for in a regional way. So that part of that regional connection is very important. And we're going to be doing that in the planning that we're doing. And again, it's a combination, as you said, of certain standards, which are really national standards that people have written about, as Assemblywoman Gunther said, from SAMHSA, from the APA, from all kinds of groups, using those, but also looking at what a region has. So for example, if a region has certain services right there already that are of a certain kind, you may not need to add more, or you may need to add a very robust system. That's got to be regional. There's got to be interconnecting cooperation on a regional basis. And that's the most efficient and the most effective way to use the mobile crisis teams. And then the key thing is the training. People do have to know how to treat individuals in a caring, compassionate way with the skill set for de-escalation and the ability to help the individual accept services and then work with them for a while. It's never a one-shot approach. You have to be there for that client, that person, until the crisis is in control, and then help them, if they need, to go to further services. So it becomes a very labor-intensive process. And we have to have the staff and the expansion of our services to be able to provide that from the beginning of the crisis to the connection to services afterwards if needed, and make sure that the person can now be safely and go back, be in the community and not have to use either law enforcement or even hospitalization if it's avoidable at all.
Well, thank you, Commissioner, and I encourage you and your team to take a look at Daniel's Law. I think it is an approach that would have that transformative systemic change, and I think it sounds like it's very aligned with some of the goals and objectives that you want to do at the agency. So thank you, Commissioner.
Thank you.
Okay.
I don't think, there's no further questions? I don't see any.
I see Assemblywoman Miller.
Okay.
Yes, thank you. Just thank you, Dr. Sullivan, for being here. And I agree, you've always been, very responsive. I just want to emphasize Aileen's point that, we've heard from you again and again, that you agree, you understand, you empathize. We talk the talk, but as Aileen said, we really need to make sure that we're walking the walk, that we are getting that funding to where it needs to get this up and going as fast as we can. So more and more people aren't slipping through and not getting what they need. And the repercussions of that we've seen and we know, and it is not going away. So however, if we can get a timeline, if we can get something concrete that shows us how that funding is being directed to where we need it to get this going as quickly as possible. Thank you.
Absolutely. We're glad to give you that. Certainly the plan, as I said, the planning has to be done, but the dollars will also start being spent sooner. We only have 2 years to spend the dollars that came in from the federal government. So we have to make sure that every penny is spent on the mental health needs and on the crisis system. So yes, we're already beginning to think about startup in certain areas to enhance the global crisis services, et cetera. So believe me, we will keep you in touch with exactly how the dollars are going. We have to do that for the federal government anyway. So we'll be transparent, let everyone see exactly where the dollars are going.
Very good. Thank you so much.
We next have Angelo Santa Barbara, Assembly person.
Okay, it's working. Thank you, Ailey. Thank you, Chairwoman. Thank you for putting this hearing together. Thank you to both chairs, and thank you, Commissioner. for testifying today. I just wanted to add to what Chairwoman Gunther was the point she was trying to make as far as accessing services. I represent a lot of rural areas, and I just wanted to make that we are finding ways to get services into some of the more rural parts of New York that are sort of remote when it comes to getting services. And I also wanted to mention if there's anything that we could be working on for veterans. I know we passed a few bills this year, a few initiatives. We funded the Dwyer Fund. We also are trying to get more information out to veterans, trying to find out how we can get them the services that they need and better serve that population. There's veteran treatment courts that we expanded this year as well. So if you could just speak to that and maybe some initiatives that we're working in, any data you could share on how we can further help our veterans when it comes to mental health services.
Yes, thanks. Thank you. I think the veterans, thank you for the enhancement, for the Dwyer and also for the veterans courts. The other work we're doing is on suicide prevention with veterans. Our suicide prevention office is very involved with the Veterans Affairs Office of the state, and also with various veterans groups across the state in terms of doing some work on suicide prevention, looking at the signs and symptoms of suicide, et cetera. We also do trainings with our various clinic services, because some veterans can't utilize the VA system, and you need to have a certain special skill set to work with veterans. And so we do training in our clinics across the state for individuals, especially in areas where there are military bases and others. Sometimes families come to us instead of going to the VA for a variety of reasons. So we do a lot of training also with our mental health staff across the state to be able to serve veterans really well. And that's very important, because I think if they come to your door, you want to be able to be sure that someone knows how to work with veterans. So we're continuing that program as well. And then, you know, in terms of, I think there's a veterans conference, which is going to be coming up also very soon, which through the substance abuse and us, we come together to talk about the co-occurring disorders for veterans, with veterans.
Great. If you could send some more information on that conference, I would love to hear more about it. And also the other challenge has been getting information to veterans, making sure they're aware of the services available and making those contacts. That's always been a challenge, but you know, any further initiatives that we can work on or anything that you're working on, we'd love to hear about. And certainly we will work on legislation as well and trying to get information to veterans when they return and make sure that they know it's available.
And also through our the New York Project Hope grant that we have, which was for crisis counseling post during the pandemic. We have a special initiative in there also that is contacting veterans organizations and ways to get the word out to veterans for the crisis counseling as well. So I forgot that, but that's also going on right now.
Great.
Thank you so much, Commissioner and Assemblyman. With no further questions for the Commissioner, we thank you for your time, Dr. Sullivan. And we'll be moving on to our next panel, who's all here and ready. So I'll just introduce all these folks and then you all can go, I think one after another, and then we can do questions for the panel, if that sounds good. So on this panel, we've got a number of organizations. We have Harvey Rosenthal from NIAPRS. We have Glenn Liebman from MHANES, Matt Shapiro from NAMI New York State, and Nadia Chait, which I hope I said that right, from the Coalition of Behavioral Health. So let us start out with Harvey. Thank you.
Good morning, Senator, and good morning, Assemblywoman Gunther, and all the members of the committees for this critically important hearing, looking at issues that are so timely. The need has never been greater. The papers are filled with the reasons and examples why. The tragedies are in front of us, and the money has never been more available to us to do something about it. I'm Harvey Rosenthal. I'm the CEO of NIAPRS, New York Association of Psych Rehab Services. We're a 40-year coalition of people in mental health recovery like me, and people who provide services like me across the state. My board are peers, I'm a peer, my staff are peers, so it's very personal to us. I want to thank the chairs for the work they've already done this year on approving the crisis stabilization centers and making them voluntary in negotiations with the governor's office, the 988 legislation, HALT legislation, which is going to ban solitary confinement for people with mental illnesses, among many other things. Your rejection of involuntary treatment measures as an unacceptable alternative for a better system, and Daniel's Law, which we're very supportive of. And our hearts go out to Mr. Prude and the Prude family for the tremendous tragedy in Rochester. These actions are tremendously needed right now. I'm going to just talk in brief, I hope, on a continuum of crisis services that you'll be hearing about in the hearing throughout from my colleagues and our members. So I just want to lay out how the continuum would work. You've heard already, bits and pieces of this already. 988 will be a front door to a new system. Instead of calling 911 and getting a police officer, people will call 988 and get a hotline with a trained counselor. If that isn't enough, mobile crisis will be available. There's money in the budget for more mobile crisis teams, although I must say mobile crisis teams tend to come with police, and I think it may not be as appropriate as the teams you've heard about, for example, the CAHOOTS model. And I'll read a little bit about that. CAHOOTS out of Eugene, Oregon, crisis assistance helping out on the streets. It consists of 2-person teams of a peer and an EMT. They have been doing this for 38 years. They have worked closely in the community, very few fatalities, and they work entirely without police the vast majority of the time, and they save a good deal of money as well as lives. You're going to hear about a version of that comes out of New York City that we support, correct crisis intervention in the now, and that's out of New York City. Crisis stabilization centers, so important. Urgent care behavioral health centers. We have 3 in New York. We should see a lot more. If they're peer run, I think, that's a very special approach where the focus won't just be on symptoms, medication, and diagnosis, but the whole person in a moment of tragedy, and where they'll be paired with mental health, medical, and addictions or counselors. Short-term crisis respite programs, which are, so the crisis stabilization is roughly 1 day. Crisis respite programs, 3 or 4 or 5 days, very much of a home-like setting where people can really, bring down the pressure and get support in a very warm and comfortable way. Then we have something called peer crisis living rooms, which are crisis centers that are located in a healthcare center. You're going to hear about a whole array of these. And I think our task today is to commit to those and get them up, as you've heard before, as soon as possible and direct the federal money to really do so. I'm just looking at my time here. Okay, so I guess I just can't say enough how important it is that we address these issues now. And that this continuum is something we've never had before. We should be able to save lives, stop suicides and overdoses, and prevent the unnecessary use of police in an area where they're not, many of them don't want to be and are not the best response. So these teams of peers and EMTs, these peer crisis respite, the peer stabilization, the peer living rooms, we have expertise at every level. And our task now is to really bring them up over the next few years. We've heard commitment, I think, for all levels of government. The federal government is committing money. The time is now.
Thank you. Glenn, you can go ahead.
Great. Thank you. Thank you, Senator Brook and Assemblymember Gunther, Bronson, and all the other legislators who are here today for this timely and important discussion of crisis services. My name is Glenn Liebman, and I'm the CEO of the Mental Health Association in New York State, Mahaney's. Our organization is comprised of 26 affiliates in 52 counties. Many of our members provide community-based services, and all our members provide advocacy, education, support, and community training. Many of our members, like Harvey's members, provide crisis services. Several of them will be speaking today, and they're really experts, so it's great they're participating. Currently, we have a patchwork of services, different in almost every county. When it comes to responding to crisis in New York, that makes no sense. What we need is a seamless continuum. We're losing too many people between the patches. How do we get there? Well, let me start with two scenarios. Scenario number one, 4 years ago, a person I know broke their finger. They went to an urgent care center. They had x-rays done to confirm the break. The PA helped bandage up the finger and medication was prescribed for the pain. This was all done within an hour. 6 months after that, another person I know was in an addiction crisis. An ambulance was called that took them to a hospital. The person spent over 10 hours in an emergency room, basically ignored despite pleading by family members. They briefly saw a PA while in full withdrawal. At 4 o'clock in the morning, they finally got a room. Thankfully, things got better after that, but that family described it as the worst hours of their lives. How do I know these stories are valid? Because I lived them. The first one was my wife. The second was my son. I have heard much more horrific examples than my son's. Thankfully, he got the help he needed, even with those delays. For many, that help is not forthcoming. Imagine a world where there is a behavioral urgent care center within reach of all New Yorkers, where my loved one was seen by a mental health and addiction professional and received the medication assisted treatment he needed immediately instead of spending hours lying in physical and emotional pain in an emergency room gurney. All this while my wife and I were counseled by a family support professional. That is the world we have the opportunity to create. How do we get there? Well, I visualize the crisis services in New York as three legs of a stool. The three legs are the 988 call-in center, the crisis stabilization center, or urgent care, as we like to call them, and the mobile crisis teams. Now, I don't have time, obviously, in this time frame to discuss them all in detail, but those are the continuum we're hoping for. And the fourth leg where somebody's going to be sitting is the workforce. The workforce is essential here. We can't talk enough about, we can have the best system of care in the world without the workforce to implement it. We know that's a disaster. This is our opportunity to reframe the discussion now. The federal block grant and the increase in FMAP will provide totally almost $200 million to the New York State Office of Mental Health. This money needs to go where it is most needed, to crisis services, workforce, children's services. We cannot let this opportunity pass without an assertive and comprehensive response. Now, here are a few recommendations moving forward. We need the funding for crisis services. We will hear from several of our members who talk about the fact that they're doing all this great work, but unfortunately they're not getting reimbursed appropriately. We need to have some sort of funding from the state, some sort of, local assistance dollars to make sure that they don't go into deficit while running these programs. We need training at all levels of the continuum. We need to make sure that mental health first aid, that there are trauma-informed care training programs out there at all levels, from the 988 staff to the mobile crisis team, to the people, frankly, that we're going to be reaching out to the educators, to families, to religious institutions, everybody. We have to make sure that they have a better understanding about mental health so we can mitigate some of these crises before we even get to this point. We need family engagement. And I know Matt's going to talk about that a lot, but large part of a crisis system is driven by families. We may have to make sure that there are families, much like there are peers who are engaged, we must make sure that there are families engaged at every level as well. We need links to services. What happens after an immediate crisis is resolved? The answer must be a link to services. Crisis stabilization centers must be required to work with community providers. We need links to the community. We know there are too many incidents recently regarding law enforcement, people with serious mental health issues. That's we're very supportive of the great work that's being done in Daniel's law proposed, but we need a robust crisis system. We need startups funding for stabilization centers to succeed. We need to enact 988 legislation. New York should be ahead of the curve when it comes to planning. We need that reoccurring funding stream that we can have from the phone tax. We need that to happen. And frankly, it's minimal to people in terms of impact. We need to finally pay for our workforce. We thank you so much for what you did with the COLA, that this has to be ongoing. And we need so much more funding for the workforce. And we need to take a piece of this, frankly, this $200 million and use that for workforce as well. And I could go on, but my 5 minutes are up. So thank you very much.
Thank you. We will now go to Matt Shapiro.
Thank you. Good morning, Assemblywoman Gunther, Senator Baruch, all the legislators. Thank you so much for your time this morning. And I really want to thank both Assemblywoman Gunther and Senator Baruch for being true leaders on these issues. I listen to you speak, and I don't hear legislators, I hear advocates, and we are so lucky to have you fighting for these issues. And obviously, as you said, Senator Baruch, we really have an opportunity here to change the script, and we want to make sure we do it correctly. My name is Matthew Shapiro. I'm the Associate Director of Public Affairs for NAMI New York State. We are the state chapter of the largest grassroots organization in the country, dedicated to improving the lives of both families and individuals who are posed with mental health challenges. And you know, it's important, as Glenn said, that when these incidents happen, these crisis incidents happen, they do impact entire families. I was so glad, Assemblywoman Gunther, that you brought up the incident that happened a couple of weeks ago at the press conference. You know, that's an experience our families experience way too often, and delayed response in mobile crisis teams. And we know the negative outcomes that can happen in those difficult times. I mean, thank God we didn't have anything overly negative happen in this situation, but I think that really gave you and your colleagues a real taste of what our families have to go through all the time. And you know, we need to do better. Obviously, it is time to change the script. And we have 1 in 4 people who have died at the hands of police or people living with a mental illness, and 1/3 of those being communities of color. We need to do better. You know, when Harvey and I were in the waiting room before, we were talking to Joe Prude, Mr. Daniel Prude's brother, and when you talk to him, you can still hear the pain in his voice and the hurt. And so, you know, we're fighting for him and all the others. You know, he's just the latest in a long line of people, especially from communities of color, who have lived with a mental illness and died at the hands of police. And you know, I want to make sure we mention them too. People like Dorothy Donner in the Bronx, Deborah Donner in the Bronx, and but you know, we're here to represent them, and that's what's so important. So you have our written script. I'm going off book a little bit. We certainly, as Glenn so well and Commissioner Sullivan, you know, we certainly support the 3 legs of that stool. The 988 tied to a crisis call center that can handle these crises and hopefully de-escalate them before mobile crisis is needed. If mobile crisis is needed, we want to make sure that you know, it is a mental health crisis response, and as Harvey said, peers should be involved. And you know, and they're only, you know, right now in many communities, when someone responds, the only options are police departments in the emergency rooms, and that's why we need crisis stabilization centers and the other services that can better handle these type of situations and you know, put people on a path to recovery and divert them from the criminal justice system. That's so key. One of the other aspects, we are strong supporters of Daniel's Law, and besides having the mental health response, I know Assemblyman Bronson mentioned it before, but I think the other really important thing about Daniel's Law is creating state and regional councils. You know, we know that these issues affect different populations and different communities differently, and we know there's a lot of inequity involved here. And it's so crucial that these communities are able to explain what goes on and their specific needs and what the appropriate way to respond to a crisis is in those communities. So we're so glad that Daniel's Law provides that opportunity. One thing I want to mention, getting a little wonky here, is that we are, you know, obviously supporting the 988 legislation. It is so important that we don't just have that 988 number, but that it's connected to a full system. Glenn mentioned funding before. We had suggested a couple little amendments that we wanted to see in the bill. One, that it establish a statewide fee on residents that is a subscriber of commercial landline, telephone, mobile, or IP-enabled voice services. And we also want to see that the 988 fee can be adjusted as needed to provide for more continuous options, volume increases, and maintenance of the 988 line. So I think those are 2 small little details that are very important that can be added to the legislation. I see that we're almost out of time. I thank you for the opportunity. And as Glenn said too, the best way to address a crisis is to prevent one. And we do need more community services, as Assemblywoman Gunther said we need more beds, both in the private sector and the OMH sector. We're losing beds, psychiatric and detox beds in both. So we do need those investments, and thank you for listening this morning.
Thank you for the opportunity to testify today. I'm Nadia Chait. I'm the Director of Policy and Advocacy at the Coalition for Behavioral Health. And thank you, Senator Brook and Assemblymember Gunther, for your strong leadership on this critical issue. As my fellow panelists have already stated, this is really an exciting time to finally create the mental health crisis system that we need and that New Yorkers throughout our state deserve. At the Coalition, we have over 100 community-based behavioral health providers as our members who annually serve over 600,000 New Yorkers with mental health and substance use needs. And one of the key and ongoing challenges for our members has been what to do when their clients are in crisis. And even as mental health providers, unfortunately, they encounter situations where they need an external response, but the response that is needed isn't available. And too often, the only response available to them is police. This has been particularly hard for our housing providers. Often due to the funding for supportive housing, there is one staff member on site. So when a client is in crisis, you have one staff member, they just don't have the bandwidth to handle that crisis, but have been left without an alternative option other than, a police response. Many of our members have worked on a lot of the services that we're talking about, and to start to build those out, we have members who operate both children's and adult mobile crisis teams, as well as members who, particularly through the Certified Community Behavioral Health Clinic model, have been able to set up 24/7 hotlines for their own clients. But as we've all discussed already, these services are too limited, they're not available to enough New Yorkers, and in many cases, the response times are too long. Our members who operate mobile crisis teams have worked diligently to improve the response time, and in many cases are now able to respond within an hour. But we would never accept a response time of an hour for EMS or police. And so, of course, we shouldn't accept the same for a mental health emergency. We strongly support both the 988 legislation and Daniel's Law to really look at creating that mental health crisis team and mental health crisis system and the continuum of care, not only the 988 hotline and the answers to those calls, but the mobile crisis teams and the crisis stabilization services. I want to highlight the points that Glenn and Matt made around ensuring that we have that workforce investment and that this is sustainable. I think, unfortunately, the realities of our current mental health and substance use system is that we're underfunded. We have a workforce crisis. And the models for many of our programs simply aren't sustainable. And so as we look to create this new system, I think it's critical that we do the work to create a system that's actually sustainable, that compensates our staff for the work that they're doing, that allows providers to, instead of having to worry about making payroll every pay period, to actually be able to invest in services, to look at expanding, to be able to recruit staff who speak languages that are harder to find, to recruit staff who have specific skill sets, and to build a real career for our staff. Too often we see our staff come in right out of graduate school, we train them, they like the work, they want to stay in the work, but the salaries that we are able to pay them are so low that they leave for the private sector or they leave for hospitals or managed care. We need to build a system where we're able to keep our staff and where those dedicated and committed staff are able to stay and provide the services that New Yorkers need the most. And along those lines, I also want to highlight that it's critical that we make sure that this crisis system is available to all New Yorkers, regardless of their insurance status, whether they're uninsured, whether they have Medicaid, whether they have commercial insurance. Too often in the mental health system, we have services that are only available to certain people based on their insurance status. That's not really acceptable for any service, but it's particularly unacceptable, I think, for a crisis service. And so it's critical as we develop this funding model that we make sure that this is similar to, a police or an EMS response where everyone has the same service regardless of, what insurance company you have or what managed care plan, your Medicaid is through. So those are the key points that I would make. And I just want to thank the chairs again for their leadership on this issue.
So I just have a few questions as usual. So just to put on the record, I just want to make sure that all of you will be or have been asked to be involved in the decision-making processes. Now we're getting money from the federal government, and are they really listening to people in the trenches? And that's one thing that we should come away with, that we haven't been listening. So that's one thing. And we have the mobile crisis team. I think that they're great, but do we need a different or new approach, or do you think this model is working? And the other part of my question is, when we talk about attracting people into this profession, that when they have these federal dollars, many people leave because they don't have medical insurance coverage in some of the non-for-profits. Non-for-profits, of course, can't afford it. And the hourly rate, and a lot of these folks that do work in this profession, I would say, are women. And what can we do to shed a light on this profession, and let's call it a profession, so that we can increase salaries and give it the distinction that it really needs? That's all.
It's a lot to unpack there. Maybe I'll take the easiest part of your question first, and then we can delve into some of the hard stuff. Yes, I think all of us are involved in the 988 implementation coalition that OMH has put together. I know NAMI New York State is working on 3 of the different working groups. We'll see if they're actually listening to us. I guess that is the key question. Only time will tell. That this process has just started, but the advocates are at the table, Assemblywoman.
Really quickly, have you done a survey from county to county to see exactly what's going on, so that when we give your position paper to the Ann Sullivan of the world, that they will be able to see that no county is alike? There are increases like in areas of poverty, things like that, making sure that we have appropriate, because of cultural issues, appropriate ways to respond culturally, and also languages. Those are very, very important parts of it too. So if we're going to do this, and if we're getting all this federal dollars, I want to see it done right, with inclusion of the people on the ground, not from the top down, but from the bottom up.
I think there's been listening sessions that OMH has conducted, but they're few. And the rubber will meet the road when they're actually making spending decisions. And we're able to really see them and feed into that, not the more general. In terms of mobile crisis, Assemblywoman, I think there needs to be, as you could tell the other day, more of them. And they need to work around the clock. In some counties, they don't have them working around the clock. And that's really critical. I will say, though, mobile crisis.
Because they're not getting any money, Harvey.
That's right. No, you're absolutely right. That's why we're here today.
They stop at 11 o'clock at night, and a lot happens in the middle of the night.
It's very true. And, I think also at the same time, though, mobile crisis frequently winds up coming out with police. And I would look at these other models as well that come out with peers and EMTs.
And I would just jump in here, and, Harvey and Matt are absolutely right. I think that we all are pleased to be part of 988 discussions and, what's going on there. But again, the rubber meets the road when the money's there. And we have been engaged, and, the commissioner is great, the leadership is great, and, we have great trust in them and that they're going to do the right thing, but they need us to be part of that discussion to ensure they're doing the right thing. And I appreciate everything you're doing to make that happen. Now, I would just take the workforce question that you asked and say that this $190 million, a set aside has to be there for workforce. We have to absolutely, Nadia said it so well, we have a workforce crisis and we create the greatest system in the world. We don't have anybody to run it, doesn't matter. we have to, as much as we're putting aside for kids services, which is essential, and for the crisis services, we have to have a set aside for workforce as well. And we have to have people wanting to be part of the nonprofit sector. We have to have career ladders. We have to have all those incentives in place. But all the training, all the career ladders in the world won't happen without real dollars. And this $195 million is our opportunity for real dollars. So that's what I'll say. And Nadia, if you wanted to.
I mean, I would just second everything Glenn said on workforce. We have to use some of these dollars to invest in our workforce.
You have to know what your ask is. You have to be, like, in other words, within the field. I think that it would help us to know what your ask is in terms of salary. Would you agree, Senator?
I think any chance you can be more specific, yes, absolutely. That helps us be better advocates.
You know, and I do want to also just make one little statement on mobile crisis too, to answer your question, Assemblywoman. You know, again, we're full supporters of, like I said, Daniel's law and having a mental health response unit that includes peers and professionals, but that's not also at the expense of CIT programs. We know there are going to be cases where police will have to get involved if there's a weapon involved or potential danger. You know, that we don't throw out the baby with the bathwater here. You know, obviously, you know, police have gotten a negative rap and deservedly so. But again, we would take a pause and realize, you know, the CIT program, that's a 40-hour training that police go through. I don't know too many people that take a week out of their lives to learn what it is to live with a mental illness and how to best communicate with people with a mental illness. So, you know, police can be a part of the solution here too. I just want to make sure we realize that. And
no, I agree wholeheartedly. And you know, they're being paid for this kind of training. Nurses get training, mental health people get training. It's part of the responsibility when you join any job, and especially as a police officer. The other thing is, I want to make sure that you're really advocating for a set aside for money for salaries. That's one of the big issues here. Very big issues. Very big issues. And the other issue that, you know, we don't really address is the fact that in rural areas in upstate New York and even in New York City, most of our patients end up in the emergency department. And at this point, we have psychiatrists leaving the state of New York because the insurance costs, they won't stay here. Basically, we have no child psychologists in upstate New York, and probably not in New York City. So this whole system, I mean, if I could talk to the governor, which I really don't have access, but anybody to say that, you know, we really have to look at this from the bottom up and say that the system is broken. And the fact is, some children need to have to go to someplace to be, you know, to be examined, etc. We have kids in the emergency rooms in New York City, upstate New York, for 25, 30 hours. 30 hours without any real, like, the nurses do their very, very best. You know, the people there do their very, very best. But, you know, we don't really pay for that kind of, you know, emergency room care, and there's nobody there, and it's not their fault because we have no psychiatrists, because the insurance rates are so high and the reimbursement from private insurance is so low. So now they only take cash. So, I mean, there's a real problem in the system too that we have to address.
Elaine, I just want to point out, please, let's not be misunderstood. The federal money is one time only. So it'll come back to the legislation of the governor to fund the staff on an ongoing basis.
And I just want to add to that, to what Harvey's saying. I think we're really, here's a big opportunity here. 988, if we could get the funding through the excise tax for the phones, that's a reoccurring funding stream. That wouldn't only pay for 988, that could pay for the service structure. So we have a real window here. We have hopefully the 988 funding that will happen. We have the $200 million. We have this window of opportunity here that we really have to, as you said, Assembly member, we have to make sure that workforce is a key part of this, crisis services and kids services, but we are putting a plan together specifically around workforce as well, identifying, as you said, identifying a strategy for ensuring salaries for those in our nonprofit sector.
Thank you all. I know we've got some other folks who have questions, so I hate to ever stop this conversation, but I do want to hand it over to my Rochester colleague, Assemblymember Harry Bronson, who will have 5 minutes, if you can stick to it, Harry, to ask questions of this, or sorry, 3 minutes to ask questions of this panel.
Thank you, Senator Brooke, and I will definitely stick to 3 minutes. So first of all, thank all 4 of you for putting on the record that you support Daniel's Law. That's very important to us. But I want each of you to try to answer 3 different areas of questions. Number one, I think one of the magic pieces of Daniel's Law is the interplay between the state councils and the regional councils. And Assemblymember Gunther mentioned, are you guys being heard? Are people asking you? For me, the regional councils and the statewide councils, but in particular the regional councils, is that opportunity to give input, is that opportunity to be heard. So I'd like for you to talk about being part of the discussion through regional councils. Second, mobile crisis teams and stabilization teams. You know what, we need alternatives to emergency rooms. When somebody is voluntarily or even involuntarily transported, they need a different place to go besides emergency room. I'd like to have you talk a little bit about the connection between mobile crisis teams and stabilization teams, and then long-term treatment. And then lastly, workforce crisis. We don't have enough psychiatrists in this state. There are other disciplines, mental health counselors, family therapists, psychoanalysts, licensed certified social workers. Please talk to me a little bit about the workforce and the utilization of those other mental health professions in the field. Thank you.
I'll go very quickly, Sabir. So in terms of input at the regional level, critically important. You got rural North Country, suburban Long Island, urban New York City, urban Rochester, many areas. Each locality needs a different sort of a solution. I think Aileen was talking about the counties have to give input as well. So absolutely. And on mobile crisis teams, I think the teams and this other team, the EMT and the peers, have the ability to give people an alternative to the emergency room and take them to the crisis stabilization. The only thing that's really important, and it's in statute, is people have to go voluntarily. And centers are not allowed to accept people involuntarily. That's, because that's what's going to really engage people, get people's trust, and have them coming back. I'll stop there.
So go ahead, Matt.
I was just going to say, Assemblyman, I mentioned it in my testimony, I think that is one of the most beneficial parts of Daniel's Law is establishing the regional councils. I mean, I'm going to steal a page from Harvey's book and say nothing about us without us. And that theory is so important. Like I said in our testimony, and as Assemblywoman Gunther mentioned, only, a community can explain what their unique challenges and unique needs are. And if crises are going to be responded to in those communities, you have to really understand the community. And the only way you can do that is by talking to the people and having their input and their say on this. So, that's why we are so grateful that it is included in Daniel's Law. I think it's just as important, really, as the response. I mean, the responders need to know what they're responding to, and you can only do that by listening. So it's such a strong element of the bill. So thank you. I didn't mean to cut you off, Glenn.
No problem. So thank you, Assemblyman, for those questions. The statewide regional councils, absolutely. I'm taking the model, been around long enough to remember everything. And we used to have the subcommittee for reinvestment, we used to have the subcommittees, each county had a subcommittee of their advisory board that would be involved in the decision-making process. And that was incredibly effective. And people heard about that. And the way, it's been structured with Daniel's Law, I think that's very effective as well. So yes, absolutely. I can't emphasize how significant that is. Your second question about the stabilization centers, the links to the mobile crisis team. We have to educate. We have to make sure that people know about mental health. I think to mitigate some of these crises, we have to have full-on mental health first aid, full-on trauma-informed care education for people so they understand what happens before they have to end up in a mobile crisis setting or in the crisis stabilization centers. I'm very hopeful about crisis stabilization centers. I think there's real possibilities there. I'm very, very excited. And hopefully when 988 passes, we do have that continuum to the stabilization center. So, you know, I look forward. I use the example of my own family, and I'm very hopeful about that. And finally, engaging in you know, around employment. I heard you on Capitol Tonight last night. Couldn't agree more. I think you were spot on about the licensure piece. I agree 100% that we could be, if we don't get that happening to us, and we're going to be in a crisis. As one of my colleagues, my board chair, Bill Gedman, who's speaking later today, said, there could be thousands of already huge waiting lists. Can you imagine what would happen if we don't get that legislation passed? What the waiting list would just explode. We couldn't even have a waiting list because there'd be too many people. So we're totally in agreement on that. And I really think that we have to, again, put aside a piece of that $185, $190 million specifically for workforce. We have to identify whether it's 25%, 20%, whatever it is, and say that has specifically identified for workforce, for those salary enhancements to recruit and retain quality staff. Thank you.
Thank you, Glenn. We're going to go to Assembly Member Griffin, who has their hand up. 3 minutes, please, if you can. For this
Okay, thank you very much. Thank you, chairs, and thank you to the panel. I appreciate your leadership, advocacy, guidance, and expertise. I just wanted to say, in my district, and just being a mother of 4 here for a long, long time, my kids are all in their 20s. You know, it's not hard to see this growing epidemic and crisis. Mental health issues, there's been really an exorbitant amount of suicides in age, I would say 15 to 25, so many suicides, and so many drug overdoses, either opioid or over the counter, just so many. And it's just so sad. Like, my kids have literally gone to so many wakes of their classmates, and it's just so sad. It's so sad to see those parents. And I'm thankful because we have a great facility. Northwell Health came here, and we have a lot of our school districts can use Northwell Health. That's local. We have FCA, another great place, South Shore Guidance. So we do have some facilities, but it although it's helping many, and it has helped a lot during the pandemic, through Zoom and all that, we still need more. But I wanted to ask about the child mobile crisis. One question was, how prevalent is that now? Is that only in the more of a pilot, or do we have a lot of child mobile crisis teams? And then I'll ask my other question, and then however much time we have to answer. I do believe in many instances that police need to be part of the team, because otherwise it could put the patient, it could put the counselors, it could put people at risk and risk the safety of all. And so I just wondered, in the 998 phone call, in that network, what will be the process that this will be assessed? Like, when there are probably many situations maybe you don't need police, but there's going to be some where you do. So I wondered what that assessment would be. And then however much time we have to answer the questions. Thank you so much.
I'll just
That's
take
a
the
great
last
question.
one and just say that the 988 operator is going to have to make an assessment and about, I guess, dangerousness. And of course, the police will need to be dispatched. Peers and EMTs or mental health counselors can't do it all, but they can do a lot more than clearly they're being used now. But there will need to be an assessment tool. Probably has to be the dangerousness, running through traffic, attacking people. This does happen. But the 988 operators, their training is going to be very important here.
Right. It's interesting, Harvey. You call them operators. I think they're going to be more than just operators. And I think in the perfect 988 system, you have several checks in place. If that call comes into the 988 center, hopefully a trained counselor or a trained therapist or operator could de-escalate the situation themselves, right? And we wouldn't have to call for any sort of mobile response. But as Harvey said, they'll be the ones, they're kind of the gatekeepers in assessing, they'll try to de-escalate the situation themselves whenever possible and not have to call in mobile response. But again, they would be, trained properly to identify what type of response is needed. And that's a critical component for this to be successful.
And if I could just jump in on Children's Mobile Crisis, I appreciate you highlighting that, Assembly Member. I don't know how many teams there are statewide, but where they exist, they are really an effective intervention for the kids. And I think highlighting that the interventions that we need for children are not necessarily the same as those that we need for adults. So for example, my members who operate Children's Mobile Crisis teams work very closely with the schools in the areas that they respond so that the schools know that they're available, know what kind of service is provided, and can connect with the Children's Mobile Crisis team instead of, calling 911, having a police officer respond to maybe doing what they're trained to do, but then that results in, handcuffing a child, which is of course never what we want to see. Whereas the mobile crisis team can come in, work with the child, work with other folks at the school. And often, the way that they're set up, at least in New York City, they have 14 days to work with the kid and the family to connect them to the appropriate community-based level of care to reduce, the likelihood of future crises and really help the kid over the long term. So I think it's a great model.
Thank you very much.
Thank you,
I just
Nadia.
want to reiterate what Nadia said. I think it's a great model. The other thing that I think is important is that there are a much larger increase of school-based mental health clinics in New York State now. There are over 800. And we actually are also fighting for legislation which I think is very important too, to educate teachers about mental health. We now have, New York's the first state in the country that's mandated that students know about, are taught about mental health in schools, and that's helped change the culture of the schools. I think the next stage in that is to educate teachers and other leadership around school administrators about mental health services to, again, help mitigate crises. Thank you.
Thank you. Thank you.
And we're talking about children too. One more thing I want to mention.
Griffin. Sorry, Matt, we've so many minutes over. I've got to get to our next panel, but we can continue this conversation obviously for days. Thank you so much to this second panel for so much of your expertise. And I think it was really important that you all pointed out really how this is going to look different throughout different parts of New York State. And so your ability to highlight that, I think, is really, really helpful. And I also want to just amplify for a moment a lot of what you talked about the fact that we have never truly seen what it looks like to have folks come into a crisis that are there to de-escalate, that are there to train, that are peers or other mental health professionals that have that training. And I think hopefully we'll hear from some people who have been on the ground in these scenarios that can really illustrate what that looks like. We are talking a completely new scenario where someone who is in a crisis, it's not escalated, it doesn't become violent. In fact, it's de-escalated, they get the care they need. And I know that as we say these things, it's sometimes hard to wrap our heads around because so few of us have actually seen it work, at least here in our state. But there are instances, and many so, that end like that, and we don't hear about them because they end peacefully and people get the help they need and there's no outrage and we don't need to hear it in the headlines. So I just want us to make sure we have a full context of that conversation when we talk about things like 988 and Daniel's Law, including here in City of Rochester. Less than 7% of all 911 calls are violent. So we got to think about the percentage of emergency that we're talking about that call for a dangerousness or violence happening on the ground. So I just wanted to kind of level set, I think, to add some data to a lot of what the second panel has brought to us. So I thank you all from the second panel. We're gonna move to our next panel. So I think they're all on and they have joined us. So I will announce your names and then if you can remember your order and just jump right in as soon as the person before you is done. So we'll start with Dan Fichter, who is a volunteer in crisis management, Jessica Puro from Crisis Services, Kathy Pandakakis, I hope I got that, Human Development Services of Westchester, Ruth Lorencron, Disability Justice Program. You guys are really giving me a run for my money here. And Mark Fleidner, Director of the Disability Rights in New York. So let us start with Dan. Thank you.
Thank you, Senator Brook. I just want to thank you for inviting me to speak today and for leading the way on these issues for New York and for the country. And I want to thank the committees for dedicating your attention to these issues and honoring Daniel Prude's memory with a transformative effort in Daniel's Law to save Black lives and to save lives broadly across the state and to be open to a new paradigm. The point that I want to deliver is simply that I think 911 calls related to mental health emergencies probably have less in common with a scheduled visit to a psychiatrist or psychologist's office for therapy than they have in common with a call to a suicide prevention hotline or other crisis line. And so perhaps we don't need to be sending a licensed counselor out on these calls. We should consider sending out psychiatric EMTs, psych EMTs, who are trained similarly to mental health hotline counselors. I volunteer on a suicide prevention hotline and I take calls as a non-clinician. And many crisis lines are staffed by volunteers like me. And the people in acute crisis who are calling are looking for a way out of their immediate crisis. They're not looking for a diagnosis and treatment. They may need someone just to be with them, to listen non-judgmentally, to know that someone's willing to take the time to absorb what they're feeling, even if that takes a long time. Often to problem solve very pragmatically about how to navigate what got them into crisis, which could be something that's internal or interpersonal or something financial or legal or substance related. And the caregiver who's doing that work on these hotlines is often not a licensed mental health counselor, even in very escalated situations where the caller's life's at risk or where they're thinking about harming someone else, and that's why they're calling. The caregiver does have to be very specifically trained in the work. Including in population competency. It helps if they're given role play practice and observation, if they get a chance to participate in case conferences for continuing education, and if they're of course supervised and coached and mentored. But the experience shows that they can do it without going to grad school or med school to gain skills in diagnosis and treatment. And we also know that the outcomes may be better when that caregiver shares aspects of identity or lived experience with the person that they're caring for, which can be quite difficult to achieve with licensed social workers or therapists because Black people and people of color are so painfully underrepresented in that field. So while there isn't a licensure model for crisis counselors on hotlines or a certification that people can get in order to do it, every crisis organization figures that out for itself. I don't think that means that we need to default to sending licensed counselors out on 911 or 988 calls simply because a form of licensure already exists for therapists. For one, I think there won't always be enough therapists, and we will end up sending police in situations where programs can't be 24/7 and across their locality because there aren't enough licensed counselors they could hire for this work. Caregivers of color are overwhelmingly underrepresented among the licensed professions. And licensed clinicians aren't always specifically trained in crisis de-escalation or harm reduction or safety planning, the work that's so important in acute crisis. They may have picked up those skills, but it's not necessarily built into the profession. So rather than default to sending out licensed counselors in mental health emergencies, I would suggest we consider sending specially trained psych EMTs. This is an aspirational idea. It's a field that we would need to create, but I think that now is the time to invite med schools and psych departments and schools of social work and community colleges into that process of inventing psych EMS. If we signal to them that our communities will hire psych EMTs for this work, if they can train them, I think we can get started. And I think there's precedent for this in the creation of paramedicine itself. In 1967 in Pittsburgh, the Freedom House Ambulance Service, a Black staffed agency serving a Black community, created from scratch a 300-hour training course for people to become the first paramedics with no prereqs other than a GED or high school diploma. And so because of that, today in physical emergencies, for example, when someone has a car accident and is losing blood, we don't send out a surgeon. We send out an EMT or a paramedic who's trained in pre-hospital trauma life support. So I think we can do that again with mental health. I think if we can create a curriculum and certification standards for psych EMS that builds on the fundamentals that crisis hotlines train their volunteers in and goes beyond that to include field observation and in-person de-escalation skills and a broad range of topics that are specific to providing in-person care, not only can we staff up these programs more adequately with psych EMTs, but I think that it could also mean an on-ramp into the mental health profession for people who absolutely have that talent and for people who may be more reflective of communities across the state and could give them a chance to have a title other than peer that reflects their expertise and their training and really allows them to become fully fledged members of the mental health profession. Thank you.
I think that's a great idea, Dan, if you don't mind me calling you Dan. I was just texting the gentleman that works in my office, and I said, why wouldn't the community colleges do a non-credit course for, like get a 2-year college, a non-credit course that someone could be trained in that? That's a great idea. I'll have to ask my president of our community colleges if they're interested.
Thank you. I hope that you do. I think it has a lot in common with the way EMT training works.
Yeah, I think it's a great idea, especially, if there's somebody available and that really wants to do it. I often feel that people that have had a loved one or they've had the issues themselves, which everybody has an issue, but what I was going to say is that they like to become involved. And I also think it's very good for their health and well-being to become involved in that too. So thank you, Dan.
Jessica, we'd love to hear from you. Thanks.
Hello, Assembly Chair Gunther and Senate Chair Brooke. Thank you for this opportunity to speak to you and the honorable members of both committees about this critical conversation and an amazing moment in our lifetime to enhance New York State's response to mental health, especially the specialty care of crisis hotlines and mobile crisis response work. My name is Jessica Pirro, and I'm the Chief Executive Officer of the agency called Crisis Services. I know we're saying Crisis Services a lot today, but our agency's name is actually Crisis Services, and we are located in Erie County. Our organization is a private not-for-profit that began in 1968 as a 24-hour suicide prevention hotline and has grown to one of the most comprehensive crisis organizations in upstate New York. Since 2004, we have served as the network center for the National Suicide Prevention Lifeline, and will be responsible for the calls serving the Western New York area through the new 988 system. We are the people you are mentioning, listening to, who are in the trenches each day providing this crisis work. I'd like to thank you both for your leadership in initiating the beginning legislative bills to establish a 988 rate fee, highlighting the need for new sources of funding to build critical financial investment into the crisis response continuum of care. Without increased financial support for a system that has been under-resourced for decades, our vision to move our mental health system forward will flounder. We need to invest in our workforce. We've heard that a lot today, our infrastructure, and our overall mental health system of care to honor those we have lost to mental health crisis, those living successfully with mental health conditions, and those yet to access our system of care. And during Mental Health Awareness Month, we need to remember those and learn from our past, honor the present, and do better for our future. In addition to my 22 years as a crisis response expert, I proudly serve as a board member of the National Association of Crisis Organization Directors and represent so many voices of crisis hotlines and mobile teams across our country. We are proud of this moment that 988 has brought to the mental health crisis response system, but it's needing to bring equal positioning to crisis work similar to other emergency service providers. While we applaud these efforts, I strongly advocate for the historical content expertise of crisis lines and mobile services to be heard, listened to, but mostly modeled after. I witness each day to the life-saving work our crisis first responders provide here in our community in Erie County. Our hotline counselors average over 250 calls each day, providing intervention and support. Our mobile crisis teams service just under 400 intakes a month, providing quality mobile response crisis care. It's easy to look outside ourselves for ideas, suggested models, and better systems, but I do challenge us to look inside of our state. Organizations like Crisis Services has been operating since 1968. 53 years strictly managing hotline calls, navigating systems of care, while also rising up our stakeholders and partners on best practices response to individuals in mental health crisis. Crisis Services, like many other providers, are responsible for the implementation of CIT training in our community, specific for law enforcement, as well as we're working with our local 911 dispatch. It helps our coordination of care, but ultimately improving the response for our most vulnerable. As noted, our services have been underfunded, under-resourced for decades. The legislative decision on funding for 988 will help us build up our existing infrastructure and honor the value of crisis work. Our crisis first responders deserve to be making equitable wages to other roles in the emergency service response system. Any established funding for our system also has to allow for administrative support, supervision, technology infrastructure, and critical marketing. All of these pieces will help us make 988 and accessing our system of care most effective. Today, you will hear from many amazing organizations on the various points of mental health system as a whole. But I'm here, and I think I'm one of the few here, although Dan, I honor what he said as well, to highlight the first step of the crisis response system, which is crisis hotlines. Did you know that 80% of calls received by a hotline counselor are resolved by the hotline counselor? Their expertise in managing hotline calls hour by hour, 24 hours a day, helps triage, intervene, and effectively and efficiently connect to the appropriate level of care, including mobile crisis teams. The goal of crisis hotlines is to divert unnecessary calls to law enforcement, divert from hospitalization, using our mobile crisis response teams, and redirecting people to the behavioral health system that is person-centered and trauma-informed. In addition to our hotline expertise, we have over 40 years of running our mobile response teams, and we are able to manage well over 60% of those calls without law enforcement involvement. Crisis hotlines have a high stabilization rate and a low cost per interaction in the continuum. So I ask you to listen to us, model us, and help us devise an effective and efficient response system for New York State. As I leave you today, I do encourage us to promote smart growth by increasing scope and capacity in stages. Hotlines and mobile teams are the backbone of our crisis continuum of care. As we launch 988 next year, our New York residents deserve a system grounded in solid expertise, but also well-funded for its success. I do hope that you'll consider these recommendations today and know that there's individuals like myself and organizations like Crisis Services ready to help devise and make sure that the system we're working towards for New York State residents is a success. Thank you for this opportunity.
Thank you. We will now go to our next panelist, Kathy Pendakakis.
Thank you.
I hope that was correct.
It is. Thank you very much. Good afternoon, committee chairs. Thank you for your leadership on this important issue. My name is Kathy Pendakakis, and I am the CEO of Human Development Services of Westchester. HDSW is a community-based not-for-profit organization in Westchester County. We do provide multiple services, and I thank you for providing an opportunity for me to share with you today our experience over the last 3 years of operating a living room crisis day respite program, which is open 12 hours a day, 365 days a year in the community and serving people throughout our county. We were extremely pleased to see the living room included in the proposal to offering a tiered menu of crisis stabilization services here in New York State. All 3 tiers, we believe, are important as they each offer varying levels of support and service. HDSW has been dedicated to creating an alternative for people in crisis that works. And although we have been operating this program through grants and fundraising, it is not sustainable, and we advocate for funding these programs. Often people in emotional distress seek assistance in hospital emergency departments, which are quite honestly often not the best choice for people in crisis. We, along with others who operate living room programs throughout the country, know that people in crisis are best served in a non-clinical, recovery-oriented, trauma-informed setting. Since July of 2017, guests of our living room program have found safe harbor in the calm, safe, and secure home-like setting they find when they walk through our doors. All guests are welcomed no matter the crisis. We have seen every type of crisis: panic attacks, anxiety attacks, prolonged isolation as a result of increased depression, thoughts of suicide, issues with substance use, and many more. Guests are greeted by New York State certified peer specialists, people with their own lived experience, and receive services and supports from peers and a mix of para and professional staff on hand. Along with the ability for staff to offer a variety of assessments, we offer services that include mindfulness, guided imagery, wellness, self-management, and time. Time to talk, share without judgment, and opportunities to create solutions to address crisis. Our guests share that time, support, and not being alone. Our guests share that the time, support, and not being alone are the best things we offer, and we've seen it work. Guests may visit for an hour or can stay for 10 hours or more. The time offered provides an opportunity to sit with a peer specialist to pinpoint what is causing distress and create a wellness recovery action plan to identify both short and long-term strategies and solutions. On top of not being the best choice for someone in crisis, emergency departments, as we know, are expensive. An average emergency department visit costs approximately $500. Our living room average cost per day to serve 6 to 15 guests is $1,300. Having provided 5,800 unique face-to-face units of service in over 17,000 hours over the past few years, we have surely provided cost savings to the system. Having limited time to share with you today, I would like to close with what one of our guests has said and shared about having access to the living room program. 3 years ago, I thought my life was ending. I was alone, about to become homeless, dealing with PTSD, addiction, and suicidality. The living room provided a safe space to heal, to talk, to laugh, and cry. I call this place my home. I feel safe and I am comfortable to be myself. The living room has kept me out of the hospital. I have been given the opportunity to rise up for the first time in my life. I wake up in the morning wanting to live. Coming to the living room showed me what matters most, the importance of understanding mental health, to find connection, and to never give up. Thank you.
Thank you. We will now have our next panelist, Ruth Lowenkron.
Thank you. Good morning, everyone. I'm particularly appreciative of the legislature's interest in this area. A huge shout out to the chairs, Senator Brook and Assembly Member Gunther, for, as others have already called it, your advocacy in great measure in this realm. Specifically excited about the development of crisis stabilization centers from the last budget, recognizing that has to be a voluntary tool. Very excited about your legislation, Senator Brook, on 988. And of course, we'll focus on my excitement, if you will, about your proposed legislation, and a shout out to Assemblymember Bronson as well on Daniel's Law. My name is Ruth Lowenkron. I'm the director of the Disability Justice Program at New York Lawyers for the Public Interest. My organization has been advocating in the mental health sphere for over 45 years, and crisis response transformation is a high priority for our organization. I personally have been involved in the issue from the second day of my employment there, when we experienced as a community the horrible, tragic loss of Deborah Danner, killed at the hands of the police in what should have been an opportunity to help a woman in distress. And what I did at that point was look out to figure out who in the community was working on this issue, and I discovered Correct Crisis Intervention Today, New York City, and I've been working with them since that time. And that's the organization, by the way, that Harvey Rosenthal mentioned. And what's important is we are all describing, I think, different places on the continuum of crisis response. This is that exact moment. Oh my goodness, someone is in front of me. What can I do? Call 911. You get the police, you could end up dead. No, that is not how we want to do things. We want to be able to have a substitute number with 988, and we want to have a real substitute for the police. I have nothing against police. I take Assemblymember Gunther's approach. They are just not the right people to be doing this, and we are not talking about a criminal matter. We're talking about a health matter. So what we need, and I'd like to say very loudly, maybe just to wake everybody up, I have the answer. And I say that because I have, with Correct Community, now I can't even say my own name, with Correct Crisis Intervention Today, New York City, we have developed a model that is based on the CAHOOTS model that folks have been talking about. It's a nearly 40-year successful model. And what we want to do is bring that model to New York. And it is able to encompass all the various factors we've been talking about here, the crisis hotlines that my panelists are talking about. But most critically, it brings to bear the emergency medical technician, to the extent you have any kind of medical issues that are being masked by the crisis. And it brings most critically the peer who has been there, who understands, and that is the person who can be trained, and that's critical. An absolute training program. Cahoots uses a 500-hour training model, and that's what we have in mind. I've shared that with the chairs. I will share it with anyone who is listening. That is what we hope can be imported into the brilliant Daniels Law. So we appreciate very much the structure that Daniels Law brings, but we think it needs some strong, detailed direction, and that's what the CCIT-NYC model brings to bear. In a nutshell, police removed. Why? We've talked about the stats already, that 18 individuals in New York City alone killed in 5 years. And of those, 15 individuals of color, over 80%. I heard another statistic, but it is over 80% affecting people of color. So we want to remove the police. Not only will eliminate deaths, injuries, maiming, but it will also eliminate forced hospitalizations and entry into the criminal legal system. We want to ensure a number other than 911. We want to ensure that it's a team of trained peers and emergency medical technicians. We want to ensure that it is a community-driven effort. As everyone says, the communities are the ones in the know. The community can best serve their community, and they recognize the differences culturally of the individuals who are there. That's another critical hallmark. We want to have an oversight board that consists 51% of peers and individuals from the communities that are served. And most critically, and it's incredible we would have to even mention this, I know my time is up, I'm going to speed to the end, but this is critical. You cannot be thinking about a different response time for mental health crises. That is nothing shy of unconstitutional and discriminatory. So we absolutely need to have the same time. So those are the hallmarks. And I will just add quickly that this is not at a great cost. We have calculated out in my written testimony, you will see that this comes also at a savings to the state. And what I just urge is, do not follow the models. I'm from New York City. Do not follow the model that Mayor de Blasio is putting forward. Do not follow the model that the New York City Council is putting forward. Follow the CCIT-NYC model based on Cahoots. Import that into Daniels Law, and we will have the system we require for our residents, our citizens who are in the greatest need. Thank you so much.
Thank you. And now we will have our final member of panel 3, Mark Fleidner.
Hello. First of all, in case I run out of time, 988, yes. Daniels Law, yes. Interested in the details, and psych EMTs, yes. I'm very grateful for this opportunity to address this issue on behalf of Disability Rights New York, where the state's congressionally mandated protection and advocacy system for people with disabilities. I'm Mark Fleidner, director of the PAMI program at DRNY, which provides legal advocacy for people with mental illness. My comments draw largely from our recently published document entitled Systems in Crisis, Identifying Critical Issues in Response to Mental Health Crisis Calls. Copies available on our website. Glad to send one directly to any of you who are interested. When the nightmare video revealing the circumstances of Daniel Prude's death in Rochester came to light in September of last year, my PAMI team, we stopped what we were doing. We gave ourselves 6 months to take a deep dive into the issue. We recognize that the issue is instinctively approached from a place of deep emotion. People with mental illness and those who advocate on their behalf, DRNY included, are unwilling to accept another death, more harm, no accountability when someone requiring assistance while in crisis is killed by police responding to 911 calls. Police departments, in their capacity as paramilitary organizations charged with keeping the peace, see that their powers and judgment are being questioned, and with the potential to have some of that power taken away, and that's something they never tend to find palatable. Our goal was to analyze the issue in a cultural and appropriately historical context and reach some reasoned, well-supported conclusions. We partnered with John Jay College of Criminal Justice in doing so, and we collectively asked ourselves, is replacement of police officers as first responders to mental health crisis situations in fact called for? If so, what are the factors to be considered in development of that replacement model that we're discussing today? Our answer to the first was yes. Based upon the historical context in which police were rather accidentally, even lazily placed by communities in a lead role in almost everything that comes through 911. And yes, based upon the ingrained and pervasive culture clash that is ignited when police and people with mental health diagnoses, overwhelmingly Black, Indigenous, and people of color, interact under crisis circumstances. Police have always been the wrong fit for response to these situations, and the potential for harm when they do respond is at least as large today as it ever was. Let us think about it. Police culture defines response to mental health crisis calls as one of the big 3 types of calls that place them in the greatest danger. They therefore respond to these scenes with the presumption that they are in danger, armed with their service weapons, handcuffs, and restraint techniques, without the skill set to de-escalate the situation. Now, commanding officers and union bosses may default to a place where they want to maintain the power, but do we really think that police officers embrace being required to play a role that they are fundamentally unprepared to play? And of course, from the other perspective, people in mental health crisis bring to this interaction a litany of negative lived experiences. Many of these folks have experienced significant trauma, quite often racial trauma linked to the institutions of policing, with the presumption that police are going to harm them or take them into custody. Where both parties come to an event with fear and distrust of the other, how could we possibly expect that it's going to end well? I just want to check my time so I can act accordingly. To the critical question, if police are to be replaced as responders on these calls, what's the model for replacement? Our consideration of this issue led DRNY to conclude that the precise model each community adopts has to be developed based on their capacity, the community's resources, human mental health resources, and potential resources. We have real problems, particularly in rural areas of the state, in terms of meeting the needs of those with mental health diagnoses. Stakeholders from all disciplines who will be impacted must be engaged in development of the model, even if they're not happy to at first, rather than a dynamic where local leaders kind of pay lip service to the input of stakeholders and then present a model that meets their political objectives. DRNY supports adoption of a multidisciplinary team model to include mental health professionals, peer support, as like I said, love the psych EMT idea, and utilization of crisis stabilization centers. By its nature, multidisciplinary work requires a level of buy-in that starts with listening to each other. You all did it with criminal law reform, achieved something large that at some points probably seemed insurmountable. This is the time and place to do it again. On the topic of criminal law, I want to reiterate some of what my colleague Ruth had to say. Provisions of the mental hygiene law that are activated when a police officer responds, they afford him, he or she, wide authority to make determinations about the state of the individual's mental health, determinations they are woefully prepared to make, and then detain and remove them from the scenes. Often, this is folks' homes. Police rather uniformly refer to these detentions, you all know, as mental health arrests. There should not be a presumption that a person who needs help is subject to arrest. These removals invariably end up generating involuntary commitment proceedings, depriving folks of their freedom for weeks, months, years. Folks are routinely charged by police with offenses like resisting arrest and attempted assault, and thereby sent off to criminal court where all of the stigmatization that they face their whole lives is simply outlined and stays with them. The reality is the harm created in this moment when police make these decisions can negatively define their lives forever going forward. I have some ideas about components that I think folks need to be looking at as we look at the details of the proposal, but I do want to state that DRNY is always fighting to be heard on these issues, and I really appreciate the fact that there's supposed to be some localized input, but we haven't heard from them yet. So I can't thank you enough for your advocacy on this matter, and greatly appreciate the opportunity to be heard about some of the exciting things that you have put before the public and the legislature. Thanks.
Thank you so much to our panel. I'll give a moment, Chairwoman Gunther, do you have any questions for this panel? Oh, you're muted.
I don't have any questions at this point in time. You know, the one thing that I think is important for all of us to work together I think that, as far as like police responding, I was listening to somebody and responding. I mean, in a rural area like mine, we only have volunteer ambulances and police do respond. And, we have a group of people that we actually sit down with, and we do try to work with our police departments and our emergency rooms. I know that there's a much better way to handle it, but I do think that at this point in time, until things move further, that we have to work with some of the resources that we have. And Dan, I loved your idea. Again, I'll say that I think that's a really great idea. And if you can send me your number, I'm going to give you a call. But I thank you for all of your input, and thank you for all the services that you provide to so many across New York State. And man, I'm ready to work with you to improve the quality of care that we can offer, and especially too for children. So thank you.
Great. I did want to follow up on some of what Chairman Gunther brought up as well, because I think it is really interesting and perhaps new information for a lot of people who are watching, this idea around volunteers doing this work. And for a lot of people, that seems like something that could never work. You have to have a licensed professional. It has to be a certain type. But I do think it's important, just like the chairwoman brought up, we've got volunteer firefighters. We have volunteer ambulance corps members. In fact, we are in EMS Appreciation Week. And just yesterday, I was with a group of volunteer firefighters who run into burning buildings to save people's lives and are volunteering to do so. So certainly that's at least on par with the kind of expertise that we need in terms of a mental health response. So I was wondering if anyone could speak to the positives, the pros of being able to use a volunteer corps like that, especially as we think about the need. I think a couple people brought it up, especially as we think about the need to diversify, whether it's linguistically, whether it's culturally, whether it's regionally, in terms of the people who are taking these calls or showing up on the scene to really relate to the folks who are in that crisis. Can anyone speak to some of that importance and or some of the training that allows people to do that work successfully?
I will jump in, Senator, but I'm not sure I'm going to say what you want to hear. I'm concerned that we have such a critical function that we would want to have treated by volunteers. I was very much struck by the prior panel talking about the need to pay people for the work that they do, and this is critical work. And I understand that if we're trying to fill a gap for a certain amount of time, that's one way of thinking about it. But I think let's listen to maybe what Harvey and the prior panelists said, that now's the time with money there to be thinking about how we can put a real system in place where people are paid, where people will really show up, where it's going to be 24/7, where the response time is going to be commensurate with the other response time. I will just say, though, that it does not have to be a level of profession. And I think that's what's so important. If you look at the CAHOOTS model, that you have people who are just given the title crisis worker, and the fact that it's not so professionalized is great. They say that their workers are 75% peers. So we're not talking about having to involve high-level professionals, but we are talking about having people who are paid for the critical work that they're doing, and that they are then trained to do that work. So with due respect, that would be the route I would prefer to see this, and that the state, I think, must take.
If I could just offer quickly, I think when you look at the hotline model that's been in existence for many decades, it really all started on volunteerism. It started on individuals coming together in their community, trying to determine how to have a place for people to call. So organizations like ours and other crisis centers across the country have very robust training curriculums that are put in place to get somebody prepared to answer these calls. I think we also have to remember the intensity of crisis calls, the trauma that people are receiving, and making sure people are properly prepared and able to manage through that with somebody on the line. But that can be done with proper support, supervision, as well as ongoing training and kind of booster trainings, if you will, on the many layers of what a mental health crisis looks like, as well as the need for assessment specifically around suicidal cases. Strictly when you look at the hotline work, it is grounded in volunteerism. I know there's centers, that even here in New York State, the hotlines that still have a solid volunteer pool answering those hotline calls. So I think when we look at the model for the state, I know it's a cumbersome thing to think through, but there's so many benefits offered by community, for their community, what's working well in their community. And I wouldn't want us to kind of have a broad brush that eliminates the needs of the individual community and people wanting to invest in their community to give back on, for example, crisis hotlines. I think the mobile response teams, there's different models that can be reviewed with that. With that though, we would then have to really evaluate our mental hygiene law and what changes need to be made at the law level of how those designees are determined by each county, specifically for individuals where we might have to make a decision to have further psychiatric evaluation at a local hospital or program. So I think there's definitely ways to incorporate the volunteer role. I just think it depends on where you're looking in the continuum of care for that. And obviously peer specialists are partnered with all of these points in the system. And we, here at Crisis Services have them connected with our mobile teams as well. So I think there's a couple different ways we can go about it. But I do think that we wouldn't want to lose volunteers specifically on our hotlines when any legislation is formed, because that is such a critical resource for us, especially right now being undersourced.
And Jessica, can you just clarify you may have said this already, the makeup of volunteer versus paid full-time?
Well, I can speak specifically for our organization. Anyone who's interested in volunteering to serve on our hotline, they go through the exact same training that our staff go through. It's 40 plus hours of training. Then there's going to be observation shifts where they're observing our seasoned counselors. Then when they start to take calls, we're observing their calls, assisting with those calls before they're just let to go on the line. Because there's just so many moving parts with every type of crisis call, that support as a team is really critical in the hotline space. So our volunteers, are given that same exact training as our staff. It's just that our staff are doing it day in and day out, where our volunteers might be a shift a week. So we want to also pay attention to supporting them when they get back into, their volunteer role each week or whenever their shift is, that they have the support they need to manage those calls. So a combination of volunteer and paid staff is really critical for the success of any crisis program, because there is liability, risk, and assessment that we have to make. And that does require, individuals who have some seasoned expertise sometimes in some challenging calls.
Thank you. All right, my 5 minutes is up, so I'm happy to hand it over to the next legislator.
Thank you, Senator. We now go to Assemblymember Harry Bronson.
Thank you. So in Daniel's law, we set forth a requirement that the state council work with SUNY and others to develop a curriculum for training and education of those individuals and units that would ultimately be certified to perform these tasks. It anticipates that some of the educational component would be, credit hours, others would be non-credit hours. It also requires that strategies be put in place to make sure that we have inclusiveness in these units, and in particular marginalized communities, communities of color, individuals of color, based on sexual orientation and identity, and other criteria, including geography. So my question is, and Dan, you talked about this a little bit in your comments about, developing a program and getting people certified. So my question for anyone on the panel that wants to answer it is, number one, what type of education and components do you see that is going to be necessary so that individuals and units can get certified? And number two, what strategies have you thought about already to make sure that we have individuals participating in the crisis intervention units that represent the communities that they're going to serve, and in particular, marginalized communities?
If I may, I'm thinking back to a system that I worked on decades ago, which was where we created sexual assault nurse examiners who didn't exist before. It was actually in New Jersey. These were folks that came from all different cultures and backgrounds and incorporated this into their work. I think there are a lot of different models that can be utilized to have somebody do that work. I think the SUNY piece is critical. I think that a priority has to be made to identify those with different backgrounds, lived experiences, and in terms of the training, the only thing I will say, because I'm not a clinician, is that it's critical that the training be continuing, that it be adapted to what is learned in the context of these pilots as they're going out, if you will, and that it, in my humble opinion, based on our research, it needs to be done in tandem with all the other members of the team. Everybody needs to be getting the same training, ideally under the same circumstances at the same time, because that is what makes sure that people don't get in each other's way in these very stressful crisis situations, and does the best for the clients.
I would just like to offer, I know for our organization, there are some national accrediting bodies already that have requirements for hotline and mobile teams. So there's the American Association for Suicidology. That's an accrediting body for a lot of crisis hotlines throughout the country. It's an extensive evaluation, site visit, interviewing process to be certified in that process. There's also the International Council on for Helplines. So that's another accrediting body that exists. So those I would say are, I think should be looked at. So you're working with the existing accrediting bodies for existing crisis hotlines like ours and others throughout the country that are all working to try to assure a consistent type of approach, as well as the excellence of care that we do expect off a 24-hour crisis hotline. So those would be two areas that could be looked at to kind of bring into from a local lens.
Thank all of you. And now we have to move on to our next panel, but we appreciate you being here and your input. So thank you very much.
We actually have, I'm sorry to interrupt. We have Assemblymember Judy Griffin with a question.
Oh, I'm sorry. I didn't see her hand up. Oh, okay, there she is.
That's
All right,
okay.
sorry.
That's okay, Aline. I'll be quick. Thank you to panel 3. Appreciate all the information that you provided. Dan, I love your idea about psych EMTs. I'd love to see us take that, to make it a reality. Ruth, your program sounds very comprehensive, and I really appreciate the it's wonderful to hear about the 40-year track record. I just wondered if you could briefly say where that program has operated. I didn't see panel 3 testimony, so I don't know if we have that written. And Jessica, I just wanted to mention, I appreciate your feeling about volunteers. I agree. I think they're very important. And I think no matter what programs we have, I think there's always going to be room and need for volunteers to be trained and to be added. I've seen in many organizations how effective properly trained volunteers can be. So I think going forward that they're great to use in addition to paid professionals as well. But yeah, so anything that you can give me, Ruth, I'd love to hear more about where that program has been in our state.
Sure. Thank you, Assemblymember. So I was alluding to the CAHOOTS program that is on everyone's or many people's tip of the tongue, and that's out of Eugene, Oregon. And they have been at work for nearly 40 years. And the track record that I just alluded to that is so impressive is that in those 40 years, they have offered a non-police response, working hand in hand with the police. So the police, even if not initially, are now recognizing, oh, this is an emergency matter. It goes to CAHOOTS. And contrarily, if it's not a mental health matter and rather a public safety matter, cahoots knows to go to the police. So this kind of a nice synchronicity can happen. But what's so critical in their track record is that in those years, not one single serious injury, not to the people they are trying to assist, nor to their staff. So this is so doable. And another statistic that I think is interesting to point out as well, when I said they work so well with the police, so you might want to know, well, how many times do they just hand it off? Because we have this fear, oh, but really that mental health crisis is scary. It cannot be done by others than the police. Not true, because in less than 1% of the times do they have the need to bring in the police, because they know what to do. They have been trained, and it's not rocket science. Yes, it takes training. I said about 500 hours worth, but it can be done. It has been done, and it must be done in New York.
Okay, thank you. Great to hear. Thank you.
Okay, I think that we answered all, everybody asked the questions. We thank you for your participation. I don't see the senator, so we have to move on to the next panel, and we thank you, and you certainly can contact us at any time in our office, and thanks for giving your time.
Thank you for having us.
Thank you so much.
Thank you. We will now go to panel 4. Our first panelist is Keith Leahy, CEO, the Mental Health Association of the Southern Tier Incorporated.
Sorry about that. I was on mute. I'm Keith Leahy, Executive Director for the Mental Health Association of the Southern Tier, located in Binghamton, New York. We serve individuals primarily in Broome County. I've been with this incredible organization for 20 years now, and it's been my pleasure to, work in this community and to really kind of, give back in any way that I can. I'd like to thank the legislature for the opportunity to provide testimony on crisis services and provide input based on our agency's experience with providing these services over the past several years. So first, I will say that it's been from our experience that crisis services work, and they work extremely well. We operate a short-term crisis respite program that serves individuals in Broome County, and we also offer a mobile crisis team. The composition of that team is a licensed mental health professional that works in tandem with a peer, and they respond primarily through calls that are somehow initiated by law enforcement or through emergency dispatch. So approximately 90% of our calls come by way of a 911 call or some other, law enforcement initiation. It's worked quite well in our area, and we would like to get to the point where we are looking to do more calls that would be initiated through 988, which I think is going to change how we respond or how we're notified to respond into the community. But our diversion rate, meaning the number of individuals that we do not need to, have be brought to the hospital for further evaluation, is approximately 70%. So for most of the individuals that we're going out and we're connecting with in the community context, most of them are stabilized right in the community, and they do not need a longer, they do not need a higher level of care. We provide peer support as a follow-up. So that's a way by which we're able to continue to keep that individual engaged and connect them to any types of services that they may need going forward after the crisis. Our short-term crisis respite program is another model that has shown to be very effective here in our area. Our diversion rate is approximately 90% for that program. So individuals who come into our short-term crisis respite program, which is called Our House, they are able to find sufficient support in order for them to kind of resolve their crisis. They're also able to use that crisis as a learning opportunity and they're able to better equip themselves for future crises by learning, coping strategies and other types of, ways by which to, self-resolve crises. So those programs are extremely helpful. We're very lucky to have them here in Broome County, but I really wanted to hone in on, some of the challenges with some of these programs. And one of the main challenges is because these programs are funded through Medicaid, we're finding it difficult to keep these programs sustainable in the community. We're fortunate that we work with our local, mental health department, and they are able to provide some funds to offset the cost. But if these programs were solely funded through Medicaid managed care, it would be nearly impossible to support them moving forward. So my recommendation is for the state to really look at, maybe local assistance or something like that that's going to help organizations keep these programs sustainable, throughout the state. Again, they work extremely well, but they need to be funded properly in order to, make these programs operate and stay in the community. Just touching on a couple of the other, issues that were brought up earlier, workforce is a huge challenge. I go back to Nadia's comment. We are seeing a workforce crisis. I love the idea of some type of crisis stabilization curriculum that would be implemented. We also offer a warm line, which is a non-crisis line 24/7. We receive calls as far away as Hawaii, and we take about 1,000 calls per month through that call line. We also do a great deal of work with, CIT and training officers. I think my time is up, so I will turn it back. Thank you.
Charlotte, do you want to go next?
Thank you, Chairwoman, and I thank you both chairs for the opportunity to speak today in the legislature for your attention to this important matter. I'm also honored to be in the company of so many great advocates and leaders around behavioral health. One of the fears that I have is that while we have a lot of funding available, that we will go chasing some unicorns and forget about some of the good models that already exist and all of the good grassroots agencies and work that's being done, which is so apparent today. So I want to talk about one in particular, and that's certified community behavioral health centers, also known as CCBHC. I urge you to consider CCBHC as a model for crisis intervention. They can and do operate at times as urgent care centers for behavioral health. CCBHC has a requirement already to provide 24/7 access to mobile crisis. It also provides walk-in access and extended hours. It employs a multidisciplinary approach to care, one that incorporates peer services, family support, nursing, medical screening and education, vocational services, care management, and importantly, substance use disorder and co-occurring disorder treatment. It's connected with internal and external resources to facilitate access to respite and housing, as well as alternatives to hospitalization and incarceration. It designs programs with cultural humility around special and underserved populations, such as veterans and their families, victims of domestic violence, those who are homeless, and immigrants. CCBHCs across New York State have built innovative models of care in partnerships with local government, schools, law enforcement, first responders, and healthcare workers, and have proven to be a resource throughout the trajectory of the pandemic. CCBHCs are financially sustainable. Investment in shoring them up enhances a proven model that has already a mechanism for billing for crisis and related services well into the future. Because they have a significant amount of federal funding, there is less of a burden on New York State. The current demonstration and its expansion projects have had broad bipartisan support due to their ability to improve access as well as positively impact health outcomes. Need for services is at an all-time high. CCBHCs are charged with serving everyone, regardless of ability to pay. That means they can serve people who are uninsured and underinsured, as well as those who are insured but can't access services because panels are limited. Any projects and programs that you choose to fund should, at the very least, be working toward a relationship with the CCBHC so that they may find long-term success. Surely, there will be a great need for many years to come, given long-term effects that the trauma of the pandemic has had on our communities, especially children and those who continue to face social injustice and racial bias and violence. And I'd just like to add a special thank you to Assemblywoman Gunther. She funded a pilot project for us beginning 2 years ago for a program called INSET, which is an all-peer mobile crisis team. And we very much appreciate your commitment to funding that going forward again so that we can have peer access to crisis that is enhanced and sustained and can go anywhere, anytime to give people what they need when they need it. So thank you, Assemblywoman.
Charlotte, make sure you call our Albany office. Am I on? Here we go. Make sure you call my Albany office, Tom Gatto, regarding for just a little, make sure.
An update. Okay,
Yep.
thank you.
Yeah. Dr. Charles?
There we go. Yeah, I'm Dr. Charles Corliss. I'm the director of Inwood Community Services, and I have been for 41 plus years. I represent the Federation of Mental Health Services. Thank you so much, Chairperson, for calling this hearing, and Chairperson Brooke for the same. I guess I'm speaking on behalf of the Federation of Mental Health Services. And Assemblywoman Gunther, you've met with us before. We're a coalition similar to the coalition in New York City, but sort of the smaller version of it, with lots of mom and pop, long-standing community-based operations, decades and decades of service, usually founded by neighbors in communities. We're sort of the first line of treatment. We're safety net, cost-effective, culturally competent, and we work with plus or minus 80% of a Medicaid population. So the vulnerable are really the people that come in our doors. We're no strangers to crises. We have a long history of working with the NYPD, EMS, and all sorts of mobile crisis teams, different versions over the decades. And frankly, lots of us have sort of taken matters into our own hands on a regular basis, doing home visits, doing emergency services in the street, working with the PD or EMS in our sites, by and large, trying to resolve things as best we could whenever we could. In addition, we all have 24-hour phone requirements, so people can call our clinic services in the middle of the night. We respond, not in person, but with EMS, and we try to help guide people to safety. So what I like about this is finally sort of prioritizing and really underscoring the important nature of behavioral health crises. So we applaud, the Assemblyman Bronson and everybody else who's working on this, because I think it's long overdue. Having said that, I'd like to make a simple point. I really believe this should be from the ground up, meaning that small community clinics that have been in the community for decades and decades and have what they call in the field ascribed credibility should be a little bit more engaged than just a hearing like this for a few minutes that I happen to have a few minutes to be on. In that, I think what works best is when you have clinicians or paraprofessionals or volunteers who are trained appropriately, or psych EMTs who are bicultural, somehow tied into the system, so that if not region by region, almost neighborhood by neighborhood, there's some interlinking. And there's some way that, practically speaking, if we have thousands of patients in our communities that we work with community by community, that should be tied into the system. The way it's been in the past is we call an 800 number, they do so-and-so, whatever. Maybe they come by 2 days later, maybe they can't. We decide, you know what? Let's get another friend. Let's go take a walk and go to the house, see what that person is doing. So if there are any ways in a practical way, sort of the CCVHC model starts to address that, and I think it's a good move. But to sort of bring it back to neighborhood by neighborhood, culture, awareness of people's needs, awareness of how you can kind of make the connection, and frankly, watching out for your own. I mean, for years and years, we've been very successful at Inwood Community, my particular organization. I've got people working me 15, 20, 25 years, but we don't pay a lot of money, but they're dedicated to the mission. They care about the community. They know the community. And frankly, it's family centered. It's family life kind of centered to some degree. So if that sort of piece can somehow be legislatively incorporated in this, I think it's a really good move. I mean, I know that the nuts and bolts of it will be very difficult, but I think clearly in design of this, to have community-based providers like providers in the Federation sit at that table and sort of hammer some of this out and try to find ways to make it so you have, volunteers, paraprofessionals, professionals trained, bicultural, psych EMTs, parts of these services that are actually aware of the patients that are in the clinic. So anything in that direction is sort of what I've sort of hung on to make that simple point. So I thank you for your time and I applaud you for your effort. And frankly, we're going to keep trying to do the best we can on our end, and hopefully we'll help people's lives keep improving over time. So thank you.
Thank you. Kathy Coons, please.
Thank you, Chairwoman. Thank you so much for having me here today to provide testimony on behalf of the New York State Conference of Local Mental Hygiene Directors. I serve as chair of the conference, and I serve as the Commissioner of Mental Health in Rensselaer County. As you know, the conference represents the Directors of Community Services, also known as County Commissioners of Mental Health, for each county in the state, and represents the local government units. The DCSs are county officials and have specific responsibilities and authority under the local services provisions of Article 41 of the Mental Hygiene Law, namely around planning, development, implementation, and oversight of services to persons of all ages in their counties affected by mental illness, substance use disorder, and developmental disabilities. As government partners, the DCSs work collaboratively with state agencies, namely OMH, OASIS, and OPWDD. We also work with our fellow departmental head colleagues in the counties. I do want to note that we have been in collaboration with OMH regarding the 988 initiative and regarding local crisis services in each of the counties. The people we serve never need just one service. Their needs are complex and extend beyond the scope of behavioral health care and into other distinct areas such as housing, public benefits, the criminal justice system, and the county correctional facilities. Our testimony today is providing recommendations for an effective community-based continuum of crisis services and ensuring adequate state aid funding to provide to the LGUs to facilitate the effective delivery and implementation of new crisis service delivery reforms. In addition to the local services planning function that the DCSs provide, within these plans, we have to identify gaps in services and be able to assist the state in measuring costs and outcomes to determine necessary state aid funding and other funding for mental hygiene continuum of care to cover every county. We are actively involved in hearing reports from the ground up regarding increases in crisis calls to phone lines, overdoses, deaths due to overdose, suicides, and homelessness, all consequent of the COVID-19 pandemic. We also are receiving reports of individuals who have never before sought services and are needing services at this time. All of our local providers have wait lists, and we have a high demand and low supply right now in the community. What we would like to see is that we develop crisis services that will relieve the law enforcement professionals from having to intervene in the state in these behavioral health crises, and develop services that can either divert from law enforcement entirely or to support law enforcement when they are responding to calls. As the LGU, we work very closely with our other stakeholders in the community, seeking to find ways to fund services. We implore you and your colleagues to work closely with the county mental health commissioners and all other relevant stakeholders to identify unique models that would result in decreased costs, but most importantly, save lives. One program that has recently caught attention nationally is a new program out of Denver, Colorado called the STAR program. This program replaces law enforcement with paramedics who are trained and licensed clinicians who respond to low-level incidents that would have otherwise fallen to patrol officers. In the first 6 months of the STAR operation, 700 incidents received response. None of these calls required police intervention, and none of them led to arrests or jail time. There are other unique models that we would recommend, but most importantly, we want to draw your attention to the need for a no wrong door policy in crisis services. That persons with co-occurring disorders are needing to be served. These are not only individuals with addiction and mental health needs, but also individuals with intellectual and developmental disabilities that co-occur with addiction and mental health needs. One such program that is in existence and has been in the Capital Region is the Children's Mental Health Crisis Team out of Parsons Child and Family Center in Albany that serves both all persons with addiction issues, persons with mental health issues, and persons with intellectual and developmental disabilities. That's an ideal program model to look at in terms of integrated funding and integrated multidisciplinary expertise. I thank you for your time today.
Thank you. Chairman Gunther, did you have any questions for this panel?
Just a quick thank you to all of you for participating today. We appreciate all of your input. Again, I know that the Senator and I, you can find our number online or in the Assembly book. And if you have any suggestions regarding legislation or you want to talk to us personally, please feel free to give us a call, because we're really interested in doing the right thing. And also we're interested in passing legislation that makes sense to all of you. So thank you so much.
Thank you, Chairwoman. I do have a quick question, because I think that many of you talked about the different regions throughout the state and some of the work that you're doing, and something that keeps coming up today is really the importance of having a regional mentality around making sure that folks get services that make sense for them. So I'm curious if you can, I know, there was some concerns around how perhaps with Daniel's Law specifically, regional councils may interact with existing groups that are really connecting resources. Have you thought about what that work might look like and how you might work in or with some of these regional councils to make sure that folks who need the services are getting connected to them?
If I could, we'd like to be part of the regional council as a federation, and we've not been invited. We're not involved, and frankly, we're on the ground and probably should be in all kinds of ways. So however that could be facilitated would be terrific.
Thanks, Charlie.
I'd like to respond from the conference's perspective. The conference has been actively involved in regional planning and regional determinations of service delivery and solutions to fulfill needs through the regional planning consortiums that the conference has been a part of sponsoring with the help of the State Office of Mental Health. So we have already developed a mechanism by which to do regional planning and regional problem solving and research on a regional basis involving multiple stakeholders across each region.
Thank you, Kathy. I know that I won't speak for my colleague, the Assembly sponsor for Daniel's Law, Assemblymember Bronson, but I know that we will likely be interested in talking more with you, as well as Chairman Gunther said, to get in touch. Because I think that what you both have highlighted is there are places where there is a robust system and there are places where there was really nothing. And so being able to create some sort of uniformity across the state is one of our goals, and learning from regions that seem to be getting it right and that have some of this infrastructure, I think is going to be really crucial for us to actually roll this out statewide, so that I think someone said it well with there's no more patchwork. It's actually consistent, and wherever you happen to be traveling or living throughout New York State, you know that you'll get the services you need. So thank you all so much. I'll take a quick look to see if anyone else has questions. And we do have Assemblymember Bronson. See, I said I couldn't speak for him, so he can speak for himself. Go ahead, Assemblymember.
Senator, I actually just wanted to chime in and say, yes, I agree with you 100%. The whole purpose in setting this up is for statewide standards, but to have regional councils develop what exists on the ground, and to have folks like the panelists here, and thank you all for your testimony and for your contribution. Under Daniel's Law, we would look forward to continuing your contribution either as a formal part of the council or as a resource to the regional councils as they develop the approach to mental health crisis. So thank you so much.
Bronson, I think those are all of the questions. Thank you again to our panel. It was so wonderful to have you all, and just echoing what the chairwoman and Assemblymember Bronson have said, we appreciate you coming to share your expertise with us.
Thank you very much. Thank you very much. Appreciate it.
You will.
The next panel that we have is actually several organizers, lawyer, attorneys, and people directly impacted by a lot of what we're talking about today in terms of mental health crisis. We are honored to be joined by several people from the Rochester community who have been at the front lines of not only creating Daniel's Law. You know, today we talked about being ground up. That is what Daniel's Law is. It was conceptualized by a community that was hurting and traumatized by ongoing brutality in terms of how we're meeting mental health crises. And we have really just simply been the carriers of this into the legislature. So truly, truly honored to be here with Joe Prude today, who will start off this panel. The brother of Daniel Prude, and we honor and respect and cherish the time that you give us, Joe, and the leadership that you have shown our city and our state as you grieve your own family. So thank you for being here with us, and then and we'll announce the other folks after Mr. Prude speaks. So 5 minutes, go for it, Joe.
Well, you know, I would like to thank everybody, each and one of the assembly members, the directors, everybody that's involved with getting this law passed. You know, this is truly a blessing, because I don't want to see nobody else family have to endure what I had to endure with mine. And you know, it's like this is a milestone right here. You know what I mean? We can get this off the ground and running. You know what I mean? I can honestly say I know this would not take place ever again. But you know, it's like this mental health crisis thing is like, you know, a lot of people is not, how you could say, like subdued to understanding it or taking it for what it is. You know, they just taking it for face value. Like, you know, is okay, they gonna stand on doing this, or they gonna stand on doing that. But my testimony to it right now today is like, I know this is a good step. And, you know, I just want to see the change that everybody else want to see. You know, I can't elaborate like I really want to, because, you know, it's like I'm going through so much right now, and it's like my mind is everywhere, you know, and I've been trying to get it to just stay planted in one spot, but it's like the more and more I find myself wandering off, you know what I mean, inside of my head. And like, I can honestly say, you know, this really is gonna be a joy to my whole family when they hear about this here. So, you know, I just want to thank y'all all, man, once again. And I don't know how to, I'm trying to like really, I'm really at loss for words right now. You know, I really can't. It's like I'm traumatized still. You know, and it's hurtful to even try to even acknowledge certain issues that's at hand right now. But I'm trying my best to deal with it. You know what I mean? And I'm dealing with it the best way I know how. I ain't special. I ain't perfect.
None of us are, Joe. None of us are, Joe. But we're
Okay.
glad you're here, and I'm glad you're here to represent your family. It's important, and we're also sorry for what you and your family are going through. And I'm sure it must be difficult to try to put it into words.
Yeah, it definitely is. I'm not gonna sit there and exaggerate and say this is easy for me to elaborate on, but it's not. This is something that every time this subject come up about my brother, you know what I mean. It's like I withdraw from it. You know what I'm saying? And it's like, man, I just I don't know where to begin. I don't know when to start. I don't know when to stop. I just can't.
You're here today, Joe, and this is a great start because you're helping frame something that will improve the life of many and save many lives. So you know what? You should be really proud of yourself. I'm sure your brother's looking down from heaven and looking at you and saying, you know what? Thank you, Joe.
Yes,
You're
ma'am.
doing a good thing today. So you should, when you put your head down tonight on that pillow, know that you did a good thing today.
Thank you.
You're very welcome.
Thank you, Joe, so much for being here with us and sharing what you're going through. Earlier today in our hearing, folks talked about the effect this happens not just on the person who's in a crisis, but their whole family. And it's so clear that there are ripple effects into a family, into a community when even one incident happens, right? And that's why when we're looking at all of this and talking about these solutions, it's about an individual in crisis and it's about communities in crisis. And so, so we appreciate you being here with us. And I know it's not easy, but know that it's not in vain and that we continue to do work to come up with solutions to make sure this never happens again. So thank you, Joe.
Thank you.
The next person we have is from the Legal Aid Society, Elena Landresina.
Good afternoon, and thank you. I want to also thank Joe Prude for being here, and thank you, Senator Brute and Assemblymember Gunther, members of the committee, for convening this hearing on such an important and pressing issue. My name is Elena Landresina, staff attorney at the Legal Aid Society in the Special Litigation Unit of the Criminal Defense Practice. I will focus my remarks on Daniel's Law. Legal aid strongly supports both legislation. We cannot overstate how critical it is as a matter of racial justice and disability justice. The system it proposes to create will protect lives, the lives of people who experience psychiatric or substance use crises. In my limited time, I wanted to highlight just a few of the reasons we support Daniel's Law, and then use the remainder of my time to offer some proposals for strengthening the law. First and foremost, it supports Daniel's Law because it creates a statewide infrastructure to transform police interaction with people who are in crisis. And it does that by explicitly authorizing mental health response units to be first responders, and by requiring the police to coordinate and defer to such units. Second, we endorse Daniel's Law's express commitment to developing policies that will effectuate a public health-based approach to people in crisis, including minimizing non-consensual treatment, providing voluntary services, and reducing contact with the legal system. Disability rights standards and the Olmstead integration mandate require New York to administer a mental health system in a way that keeps people both safe and in their communities whenever possible. Crisis services are like any other services must divert people away from the police away from carceral systems, and away from institutional forms of care when appropriate. Finally, directly impacted individuals must be involved in developing approaches that strengthen and address community needs. We therefore support Daniels Law's provisions that explicitly establish a role for people with lived experiences and people who have expertise in culturally competent care, developing the policies and procedures related to the mental health response units. As I noted, we also urge several amendments that advance the law's objectives. First, we recommend more robust auditing and reporting requirements. Concerned that Daniels Law's reporting requirements are not sufficiently comprehensive, for example, because they don't have measures to monitor whether people are who experience crisis are compelled into involuntary treatment or if they experience unnecessary force. Without such monitoring, stakeholders will be unable to assess whether the system is really achieving the goals of Daniels Law. We believe that Daniels Law should require a comprehensive audit of outcomes of mental health response units, these responses when they occur. Second, we recommend that the legislation provide for a comprehensive needs assessment. Assessments of
Alana, you need to maybe turn off the photo part because you're blinking out back and forth. Like some of your conversation, I don't know if anybody else has it, but you're kind of going in and out. Okay. It's tough. So maybe sometimes if you turn
turn the video off. Okay, if that improves. We recommend that there be a comprehensive assessment of the entire mental health system, because crisis services are really just one part of the continuum of care that so many people have touched upon. And crisis services can only be effective and they are part of the continuum of services that prevent situations of crisis, support recovery, and address people's individualized needs. We'd also recommend that Daniel establish a role for peers in crisis response. And while the Daniels Law envisions a role for directly impacted individuals to participate, we'd urge greater efforts to support the broadest of people with lived experiences on the regional councils. We recommend that Daniels Law contain explicit provisions that would allow for reasonable accommodations to eliminate barriers to participation. And finally, we'd urge there be mechanisms for broader community engagement and input for those who do not sit in regional councils. Thank you so much for the opportunity to testify.
Thank you, Elena. I will now go to Melanie Funches, who is a mental health provider and CEO of Ubuntu Village Works.
Good afternoon, everybody, and thank you, Senator Brook and Assemblyperson Gunther, for this opportunity to address you all today. I first want to say, first and foremost, that I have a dog. I'm sorry, y'all, I have a dog, and that, I'm sorry. I want to say that I fully support Daniels Law, and I want to highlight that both of my commentary at this time will focus on culturally responsive mental health response and historical trauma and how that plays into mental health, particularly for communities of color, and why we need to have culturally responsive response and how it affects all parts of the system. Mental health does not look the same for everyone. Across, just like we're saying we need regional addresses to make things applicable to a particular region, even within that, in all the areas that my colleagues have highlighted up till now, including but not limited to the continuum of care, the workforce, and others, we need to look for culturally responsive care. This means that beyond that, just hiring people of color, this means not only hiring people of color and increasing the number of people of color in the workforce, but for comprehensive training for everybody who comes into contact with people with mental health challenges in culturally responsive approaches, services, and supports. What we do understand, as one of my colleagues has earlier stated, that there is deep level disproportionality for people of color, generally, and Black people specifically, when it comes to poor outcomes in mental health response. To say this very bluntly, Black people are the ones who end up dead. So we need a different level of response so people can be alive, so help can actually look like help. And what does that look like? That looks like from everything that when we've talked about here about having the community colleges do crisis response training. We need, just like we have crisis response training, we need training in culturally responsive support. What does that look like? We need training so people can understand the bias, because what we do understand is that if we do all these other things, we have people in our workforce who see Black people as inherently violent and as inherently dangerous. And your interpretation guides your intervention. So if you see people as inherently violent and inherently dangerous, you will interact with them in that way. So we need to do the best that we can to make sure that not only when we change this, because this is not just for cops, this is clinicians as well. We need to make sure that everyone that comes into contact with someone when they are in crisis is able to see them as a person in crisis, see their humanity first, and be able to interact with them as such. And what we need to understand is this goes to everything up to and including language. African-American vernacular English is an actual thing. And if you are not fluent, you will hear things that you will hear things that are spoken in African-American vernacular English that you think mean one thing and they mean another. And when someone's life is in their hands, we need to make sure people get it right every time. There is no room for error, because what we see is when there's room for error, people die. Also, we need to make sure that we keep talking about, well, we can build this new, we can build this new. We also need to look at the existing continuum of care and look at the existing services and make, because many times now the existing services we have are not culturally responsive. The workforce does not mirror the communities that they serve. And I don't mean by population numbers, I mean by prevalence data in the system. So if you are looking at prevalence data, how many people who shows up proportionally in the mental health system, we need to make sure that we have the staffing who are properly trained, not just in the clinical aspects, not just in crisis aspects, but in aspects of culture to address that need. I also want to say that I applaud Senator Brook and Assemblyman Bronson for their efforts in doing this, and that I think that this is a good first step, but we need to make sure that credible voices on the ground, and not just white ones, are heard as we craft this and we make this into a reality. Thank you very much.
Thank you, Melanie. Next, we'll go to Ashley Gant, who is a civil rights organizer based here in Rochester.
So first, thank you so much for having me, Senator Brook, Assemblyman Bronson, and Assemblyman Gunther. I'll just start by reading my testimony. So on Monday, March 23rd, 2020, Joe Prude called 911 to get his brother, Daniel Prude, who was experiencing a mental health crisis, help. When the police arrived, they found Daniel Prude, a Black male, walking down the street naked in freezing temperatures. Instead of rendering aid in the incident that followed, Mr. Prude was handcuffed, his head was covered with a spit hood, and he was held forcibly to the ground. One officer pinned Mr. Prude's head to the pavement while 3 other officers held his body down. After 2 minutes of being held to the ground, Mr. Prude stopped breathing. When paramedics arrived, they administered CPR, proceeded to the hospital, and on March 30th, Daniel Prude was taken off of life support and pronounced dead. We know that of all interactions, violent interactions with police, 50% of those interactions are with people with disabilities, with an overwhelming amount of people who are dealing with mental health crises. We know that police officers are not mental health counselors, and if Daniel Prude was treated with compassion and care, he would still be alive today. We've worked directly with the family and the community to make sure that this bill meets both the family and community needs, and it does. Right now is your opportunity to pass a bill that this family and this community can hold as a piece of justice. It's your opportunity to pass a bill that will allow them to continue to grieve. This is the first bill of its kind to make this big of a systematic change. you have the opportunity to make sure that New York State sets the precedent for that. Advocates all across the state are advocating for police to be removed from many situations. So let's remove them from interacting with some of our most vulnerable people, most of those people being brown and Black and with disabilities. Throughout the conversations today, we've heard a lot of these conversations being centered around funding. And while we know that is important, I want to urge you guys to remember that we are talking about human dignity of the most marginalized community, and the majority of that community being brown and Black, most of which will never, ever get the opportunity to sit at these tables, to advocate for themselves, to tell you their stories, to tell you their experiences. So we're trusting you to make hard decisions, hard choices, radical choices that go against the grain and ultimately save lives. Thank you so much for your time today. I really appreciate Senator Samar-Brook for championing this along with Harriet Bronson. We appreciate all of the work that you're doing, and shout out to all the people on the ground doing the work to make sure that we get sustainable change.
Thank you, Ashley. And the final panelist in this panel is Iman Abed Thompson, the chapter director of the ACLU Genesee Valley chapter.
Hi, everyone. Thank you, Samar-Brook, State Senator Samar-Brook, and Assemblymember Harriet Bronson, as well as all the other elected officials who are here today, and for giving us the chance to speak to why this is a critical time to pass Daniels Law. So my name is Iman, and I'm here today speaking to you from Rochester, New York, as the Genesee Valley chapter director with the ACLU of New York. I've been in the middle of the crisis and death surrounding Daniel Prude throughout the course of the last few months. And I want to thank Joe Prude for being on here today to speak on behalf of his brother, and for all the Black and brown advocates who are directly impacted, who are still pushing through the grief to make sure Daniel's Law is possible. We know that in March, Daniel Prude was experiencing an acute mental health crisis when his family called 911 for help. He was naked in the street and posed no risk to any other person. Yet Rochester Police Department responded in force, handcuffed him, placed a hood over his head, and held him face down on the cold pavement until he stopped breathing. Daniel Prude was a man experiencing an obvious mental health crisis, and he deserved care and dignity, but he was denied both. Instead, police killed him. We can and we must take steps to end the senseless killing of people like Daniel Prude. New York has the chance to fundamentally transform the role of policing in our state, and we must start by ending our over-reliance on police as first responders at every crisis. Studies show that up to 1/2 of people who become victims of police violence have a disability, and overwhelmingly a mental health disability. Tragically, for many New Yorkers, 911 has become the only option for people seeking help in a mental health crisis, and police often arrive at the scene armed and prepared to escalate with no mental health experience. The police are not mental health counselors or social workers. They lack the comprehensive training and skills needed to provide the safe and appropriate response to those in distress. Moreover, the presence of armed police officers too frequently escalates crisis situations. In worst-case scenarios, officers use force in response to a person in crisis, resulting in unnecessary and unjust serious bodily injury and death to those who simply need the care and support of trained mental health professionals. In fact, people with untreated mental illness are 16 times more likely to be killed during a police encounter than others approaching or stopped by an officer. The Washington Post's database of fatal police shootings found that 20 to 25% of fatal police shootings killed a person with mental illness, and that approximately 92% of people killed by police while holding some sort of weapon were people with mental illness. Approximately 28% of those people with mental illness killed by police were Black or Latinx. However, those numbers apparently only represent those individuals perceived to be mentally ill or at the time of shooting. So the real numbers and percentages may be much higher. One study found close to 1/3 of those killed by police were people with disabilities, and individual jurisdictions and other studies have reported numbers as high as 57 to 81%. New Yorkers and people across this nation want a true reimagining of public safety and the role of law enforcement in promoting safety, particularly with respect to people in a health crisis. Working directly with Joe Prude's family, we know that this is something that must be passed immediately to make sure it happens to no one else. Mental health crises must be treated as a public health crisis rather than a public safety issue. We have seen programs minimizing and in some cases eliminating police from responding to mental health crises. They exist in places like Austin, Texas, Eugene, Oregon, and Olympia, Washington. A report by the Albany Government Law Center notes that while the programs vary in design, there are certain critical takeaways for local governments attempting to reform and implement a crisis response program. Daniels Law actually embraces all those key elements of a successful crisis intervention model. The creation of a new agency, Home for Crisis Intervention, driven by the goal of increasing care and reducing contacts with the criminal justice system, a consistent and care-informed approach to training for all providers, beginning with dispatch, an emphasis on community-based service providers to steer clients to needed services, and the collection of data to continue to inform and improve crisis intervention. Daniel's Law provides us with a process and the architecture for crisis response that is person-centered, builds on the continuum of care, and gives directly impacted people and mental health professionals the ability to build out programs that will impact them. They will be the ones to set the rules, build out the regional response units. They will be the ones to make up both regional and state councils that develop training and protocols for all calls to dispatch. And for the first time in New York State, we can treat mental health crisis as a public health issue, not a public safety threat. Daniel's Law also sets up the requirement that the councils reflect the demographics that are most impacted by the system. People deserve a well-funded system of respite care centers, mental health urgent care centers, and other safe havens for people with mental health concerns. These services must also be easy to access 24/7 and prioritize the people most impacted. Daniel's Law will develop crisis response centers on consensual, community-informed care and de-escalating crisis. New Yorkers in crisis deserve the care and support of trained, community-based, culturally competent, and gender-competent health professionals. With Daniel's Law, mental health professionals and the first responders to mental health crisis could make a huge difference. Just want to thank everybody for their time. And again, thank you to Assemblymember Harry Bronson, as well as State Senator Summer Brook for helping us lead the charge on this.
Thank you, Iman, and thank you to everyone who joined our panel today. I'll start us off with a couple questions, and then we'll go to some of the legislators who have questions for you all. I think, we've seen both the personal experience that we've heard, stories we've heard, and also a lot of the statistics that Ashley and Iman, you were able to share. I think sometimes people really need to hear how this would be different, right? How different it might be in addition to being able to save lives. Does one of you want to speak to, say, something like Daniel's Law or 988 had been in place? How could that night have gone differently?
I can answer that. So I'll say since Daniel Prude here in Rochester, friends, family, neighbors, people have been a little apprehensive about calling the police when there is mental health situations going on. And we just had a similar situation as Daniel Prude's situation here, where we had a young Black male naked going through a mental health crisis and just really in an uproar, and his family and friends, and as well as his neighbors on the street, didn't want to call the police. And they in turn ended up reaching out on Facebook to Free the People Rock, who reached out to Melanie Funches and some other mental health professionals, as well as the community, to go and see how they could support this family. And when they showed up, they brought clothes, they were compassionate, they talked calm, they were able to talk to this young man as well as his family and get him transported to the hospital so that he can get the help that he needs. But love and compassion led the way. The police eventually did show up, and I want to tell you that when they did show up, they were the aggressors. When the fire department and the police showed up, they were the ones escalating the situation, and it was the love and the compassion and the empathy and the quick thinking of community members that decided, hey, this can go another way. We don't want another Daniel Prude situation. And because the community members stepped in and led with compassion and empathy and love, we were able to really turn a situation that could have went left, and we're able to de-escalate it and keep it calm. And this young man is still alive today, getting the help and the care that he needs, and his family is grateful for the support of the community.
Thank you. Speaking about community response.
Senator
oh,
Brooke,
go ahead.
I'd like to address this as well.
Sure.
The key is that the people need to be the owners of the tools of their own healing. When, just like Ashley has said, if we now, and I want to say this, I want to take from the place from which I speak. I am what I call a 3-generation peer. I am the child of a person with mental health challenges. I too have sought out mental health treatment for my own challenges, and I am the mother of children with mental health challenges. So I understand this both from a professional as well as from a personal standpoint. When we train our community to work, and people who are credible messengers in these things like crisis, being how to de-escalate crisis and do these things, because of the inherent way that we see people as human, we can go into situations and de-escalate. I personally have de-escalated people with guns and with knives, with scissors, with blades, with all manners of things without a hand being had to be laid on anyone. Because I see them as human first. And I use crisis de-escalation techniques, and I use humanity. And I see them as human first. We can do this as a community. And I believe if Daniel's Law had been in place and things had been in place, that we could create these things in our community, where our community can do these things, that we can put the people in place to do this address the way it needs to be done.
Thank you, Melanie. Going off that to my next question, I am curious, given that you are a provider in this field and you talked about, and Iman talked about linguistic competency, cultural competency, understanding how to handle folks with different identities and approach it in a way that makes sense for the person in crisis. Do you have recommendations on how we ensure that if and when we do implement these programs like Daniel's Law, when this law actually does take into effect, how do we make sure that the right people show up and that the right people are employed and or volunteering for these services? Do you have recommendations as to how we make sure that that is diversified?
Yes. I have a couple of recommendations. One, that the requirements for training are written into contracts and are tied to your money. And as much as we can on the program level, that they are tied to accountability. This is something that I am working on the local level too, as we are putting in training and things for clinicians, that it is tied to their performance appraisals, and it's tied to all manners of accountability. We have to have a way to say who is doing the training, because we need to make sure that these people are people who we know are competent in doing this training. Just because you can say the words cultural competence doesn't mean you can teach cultural competence. So, and also finally, is to really help people to understand that we can empower peers. What I mean by peers, I mean peers, adult peers, I mean family peers, I mean community peers, as in persons as credible messengers, and empower them and pay them, train them, pay them, so that they can do this work on the ground.
Thank you so much, Melanie. I do want to acknowledge Senator Bailey has also joined. So welcome, Senator Bailey. Thank you for being here, another member of the Mental Health Committee. Chairwoman Gunther, I wanted to give you a chance if you had questions. You're muted.
I always forget to unmute. I don't know why, but I thank you for coming to our hearing today. And I'm sure the senator and I will come up with some good legislation. And more than legislation, I think that the state of New York has to really put their money where their mouth is. I mean, it's important that we have places to go and access to to care, and access to make sure that we have professionals available. But the only way we get there is really, we've been begging in mental health for a long time to put more money into the mental health system. And this is a case that we realize that, we don't have enough help out there. And I guess also those competent that are in communities that are, it's just not happening. And, I live in a terribly rural area. I think we have 2 mental health beds in the entire area. We do our best, but it's not good enough. So I thank you for sharing, and especially Joe for sharing with us today. And if there's anything we can do to help you, we're always here. That's all I can tell you.
Thank you,
Chairwoman. And I want thank you, Joe. Again, I want to give Assemblymember Bronson who also had his hand up.
Thank you, Senator, and Chair Gunther, thank you as well. First, Joe, you're amazing. I can't imagine hearing the story over and over again of what happened to Daniel. Listening to, I think it was Iman, give the details, and my heart was just breaking. So I can't imagine what you're going through as Daniel's brother, but I thank you for all the work you're doing to make it different for future families. So thank you. Iman, Melanie, Elena, and Ashley had to run off. Thank you for your advocacy. This wouldn't have been to this point without your work and working with all of you to develop the language to move this forward, to make sure we covered the things that we needed to cover. Just a couple of follow-up questions, and it speaks volumes. It speaks volumes that the first witnesses who are Black people is this panel. And we're more than halfway through the day. My question is to any of the three of you who are here, how do we make sure that we get the Black community more involved, whether they're licensed mental health providers, whether they're volunteers and crisis volunteers? How can we do that? Melanie, do you have any ideas, or other folks?
What I would like to say is that it is a misnomer to say that we are not involved. We don't get to these tables. That's the proper question. We don't get to these tables. What we need to do is make sure that there is equity at all of these tables. We are out here. It was one phone call to me, and I brought the Black Healers Network to the fore for people to come and be in all of these things that we're addressing. We are here. It's just that we don't get called upon. Also, to bring people in, you have to have supports, not just recruitment, but retention supports on all levels. The fact is, we know that racism is a public health crisis. They've been declaring it all over the country, and the places here in New York State, and actually here in Rochester through the Greater Rochester Black Agenda Group, we have said racism is a public health crisis, and this is more prevalent nowhere else but in mental health. So we need to make steps to be conscious about how do we recruit and retain people of color in all across the continuum of care. We do that financially, we do that through support, we do that through affinity groups. There's any number of ways we can do that.
Thank you, Melanie, and thank you for correcting me in the way I worded that question. It is important to realize that you are there, and you are involved. The question is, how do we do that formally, and how do we make sure that we're listening to the voices of people of color? So thank you so much, and thank you all again for being here today. Appreciate it.
So I think we're going to move on to our next section. Are we, Senator? Thank you. And I thank you for all participating today. And certainly we're both available when you need us. So if you want to give a call anytime, please feel free. Thank you. So, good afternoon, everybody, and welcome to our afternoon part of the Mental Health Crisis Services meeting. And I guess you can introduce yourselves as we go along. And I guess we'll start on Steve. And I don't know how to pronounce your last name, Steve. So you can introduce yourselves, tell us where you're from, and continue forward.
Sure. My name is Steve Michio, and I'm the CEO of People USA. Originally People Incorporated. We've been in service since 1990. I've been with the company 22 years almost. I am the person that designed and opened the first respite in New York, the short-term crisis respites. We now have 4 in New York. I've helped open over 40 across the country and in Europe as well. And I'm also the person that designed the Dutchess County Crisis Stabilization Center, and we just began operations, taking over from the county, the operations in November. And we are a peer-run organization. I think it's important to know that there's been a lot of discussion around peers and what they do and what they can do. I think what we do is pretty amazing work. We also have a forensic mobile crisis team that does work with police down in Westchester County. The goal is to not have to work with the police, but unfortunately our system of care is still working in that area, in that direction. So I think police are still very important. And I am also on the board of CIT International, which is the group that created CIT. And I'm on it because I think everyone is right. We shouldn't rely on police to be our mental health system, or to be a part of our mental health system. So how do we move away from that? But at the same time, I think the 40 hours that these police get is one of the most incredible trainings that they've ever gotten in not only self-care, but also in working with the communities. I don't think people realize that the 40 hours that we're with officers, we get into the whole trauma of what it's like to be an officer. And when we do that, we figure out and find out why there are so many personal issues in our police departments in the United States. And so that's just one piece of, CIT and how it's beneficial. The other is that it does reduce community, injuries and workman's comp in the police departments and things. So it is a great tool, great model. It's great to have, but it's not the answer. Crisis stabilization centers, I think, are phenomenal and can be phenomenal. We've been very successful since we opened in 2017. We are a partner with other organizations in the Crisis Stabilization Center. And I think it's important to know that it's not just one agency doing the work. I also think it's important to know that if you're talking about crisis stabilization centers, that you have to have a community that is integrated. And people talk a lot about integration, but they don't really define it. I defined it, and I did a lot of asset-based community development in Dutchess County to get all of the providers in healthcare, mental health care, addiction, any service, even including chambers of commerce and other organizations that are part of our community, and got them involved in the design of the Stabilization Center and also in the interaction with the Stabilization Center. So I think it's really important that if you're going to just go out there and fund stabilization centers, that people have a place to go to after they leave the center. If they don't, then we have a big problem. So I fully support it. And I also support the respite services because our respites have been extremely effective and successful in keeping people out of hospitals. They're over 90% successful in keeping them out. Stabilization Center is over 90% successful. Our mobile crisis team is 90.4% successful at keeping people out of jail. And the important piece of this too is that we follow up with people. We don't just discharge and say, okay, good luck. We make sure that we stay connected as long as they want us to stay connected with them to ensure that they're getting the quality care that they deserve in the community. If they're not, we advocate with them to make sure that they do get those services. We're a very busy organization doing more follow-up than we are the initial engagements that we do, because that's where our system often fails. And so we figured out what works in our communities, and we serve 9 communities in New York. So we're figuring this out as we go. But I do believe there's got to be leadership, an asset-based community development process. And I also want to say there's a cost savings to this. And I didn't realize that because I didn't care about the cost of this stuff. When I found out what it did save, it was incredible. The Stabilization Center can serve 5,480 people annually and save $12.2 million a year in avoiding hospitalization or more critical care. The Rose houses, the respite houses that we have, each can serve up to 500 people annually and save $6.5 million a year. The Forensic Mobile Crisis Team serves 300 people a year right now, and it saves $5 million a year in jail costs, hospital costs, or more critical care costs. We've integrated peers into hospitals and help people discharge plans. It saves dollars, and transitional care and wellness teams also save the dollars because it avoids the crisis system. So I know I have to finish up, but I do want to thank you so much for having this and inviting me. And I really feel honored that I could be a part of this. So thank you.
Steve, when you have a chance, could you email my office your name and your phone number? Would you do that? The next person is Christina. If I may call you by your first name.
Yes, you may. Thank you. Thank you for this opportunity to allow me to speak today. My name is Christina Sparrow. I'm a steering committee member of Correct Crisis Intervention Today, or CCIT NYC. I'm the New York City Advocacy Advisor for Fountain House and a mental health advocate and a certified public accountant. I'm an African-American woman diagnosed with bipolar disorder and PTSD, and I struggle with suicidal ideations. I understand firsthand the challenges that people in the mental health community face as it relates to bias and systemic racism. Although my diagnosis was at age of 37, I believe I was born with this condition. My God-fearing mother, who was a religious fanatic, believed I was the devil in her womb. At 4 months old, my mother grabbed me from the crib, shook my body, and rattled my brain, but luckily my father saved my life. By the age of 5, my mother hung me out the 11th-story window from public housing. Later on, my brother allowed my 18-year-old brother, who was 18 years senior than me, to expose me to marijuana and alcohol. Her regular beatings and threats to kill me changed over to psychological abuse, including blacklisting me from the whole family. I was isolated, alone, with no familiar support and love. And still today, I live with nightmares, crying fits, night screaming, racing thoughts, and feeling hopelessness and unworthiness. My medications and my past hospitalizations never have and will erase the emotional pain that I have in my life. Navigating through broken systems with disabilities have been a challenge for me, but I never realized how biased police were until my first encounter. I was assaulted by a former friend, and in response, I called 911 and I said, I live with bipolar disorder and I have been assaulted, and that was a mistake. I was under the impression that law enforcement would provide me with the same level of care as a senior citizen or a child would get received, but I was wrong. Instead of police responding to me as a human being, they responded to me as an emotionally disturbed person, or EDP, as they refer. Even though I had no mental health symptoms, I was still not viewed as a human being. Instead, the police filed a false complaint against me from the assailant's husband, and the assailant was allowed to flee the scene of the crime. That day, my rights were grossly violated, and that's when I became a mental health advocate. There are far better responses to a mental health crisis, and that does not include police. We must remove police, the response equation entirely. We must stop treating mental health crisis as a criminal matter and treat people like human beings, particularly people of color. In 2017, I watched a body cam footage of NYPD doing a wellness check for Mr. Miguel Richards, and it demonstrated how ill-equipped police were to respond to mental health calls. Moments after police received a 911 call from Mr. Richards' landlord, they barged into his door. Mr. Richards was standing in the dark room with his shades, nothing, just quiet, silent. The police kept screaming at him for 15 minutes, screaming to drop a weapon or whatever they assumed that he had. The man had no weapon. There was no evidence of it, and the police shot, and the man laid there dead. That was not right. Mr. Richards died because of his diagnosis. Still to this day, there is no evidence that that man had a weapon. For me personally too, there was a situation where police knocked on my door, in which I did not know it was the police people. They were doing a wellness check for me. And I ran into the kitchen and grabbed a knife, ready to fight, and I did not know it was police. If the police would have entered my house, we know what would have happened. Like Mr. Richards, like Deborah Dana, like Daniel Prude, their lives didn't matter. People with mental health conditions, our lives matter, and it's non-negotiable. Please, I beg legislators to adopt a proposal for CCIT to have a peer-driven response model where we have one peer and one EMT to respond to people in crisis. If I was there to support Mr. Richards, whether he was in crisis or not, as a peer, I would have provided a safe space for him and approached him in a non-judgmental way with empathy, used a person-centered approach, 20 to 30-minute conversation, built a rapport to gain his trust, contacted his family and said, what is his comfort food? For my comfort food is Haagen-Dazs ice cream. So if you come to me in crisis, I'll love the Haagen-Dazs ice cream. I would have definitely actively listened to Mr. Richard and find out if he was unwell. And if he was unwell, we would have found a solution together. My job as a peer specialist is to build meaningful human relationships with people, connect people, and uplift them. So there is no options. The emotional crisis should never be solely hospital, jails, and death. It's about meeting people at their unmet needs, such as housing and employment, food, education. And it may not be the unmet need. Sometimes people need people to talk to, because I've been there. I know how it is not to clean my house at times because I'm paralyzed, because I'm depressed. But if I had a peer in my house, sometimes somebody could sit there to help me walk through my crisis. Also, peers, suffice it to say, the ones closest to the problems are closest to the solution. Peers know what an effective mental health crisis model looks like. So we must have 51% peers on these mental health councils. And as we say in the community, nothing about us without us. Let peers help you. We are waiting to stand with you and work with you. Thank you.
Thank you. Thank you. Nothing without us is about us, right?
Nothing about us without us.
How to write it down. Thank you, Christina. I had to write it down. Next person is Jeffrey or Kim, whichever wants to go first. It's up to you. Kim, do you want to go? Oh, Jesus. Can you hear me?
Yes, I can, sure.
Okay,
Yes,
go ahead,
happy-
Tim. And
Thank you. Yes, thanks. Good afternoon, Assemblyman Chair Gunther and members of the Mental Health Committees. Thank you for the opportunity to testify in support of Senate Bill 6194 in relation to establishing a 988 suicide prevention and mental health crisis hotline system. My name is Kimberly Williams. I'm the president and CEO of Vibrant Emotional Health, which for 50 years has been at the forefront of promoting emotional well-being for all through our programs and work administering crisis lines like the National Suicide Prevention Lifeline. We serve millions of New Yorkers and other individuals across the country who are at risk of suicide or mental health crisis annually. We applaud Senator Brook and co-sponsors of the Senate Bill 6194 for introducing legislation that would allow the state to be a leader in crisis care throughout the country and to better serve individuals in crisis. This legislation will prepare the state for the transition to 988, ensure crisis services are connected and coordinated, and provide a mechanism for sustainably resourcing the crisis continuum. Vibrant is proud to serve as the administrator of the National Suicide Prevention Lifeline since the program's inception. The Lifeline provides free and confidential emotional support for people in emotional distress 24 hours a day, 7 days a week. The Lifeline network consists of 180 independently owned and operated crisis centers throughout the country, including 10 crisis centers in the state of New York. Congress and the FCC have designated 988 as a universal 3-digit dialing code for the Lifeline, which will increase accessibility for these life-saving services, extend the national reach of suicide prevention efforts, and reduce stigma surrounding mental health. Unfortunately, there are areas of the state that do not have a crisis center providing Lifeline services, or in the case of some areas of the state, the demand exceeds the capacity. This lack of complete statewide coverage and capacity could result in individuals in crisis waiting longer for support or connecting with an out-of-state backup center that is less likely to connect the individual to local community resources. In 2020, 30% of all calls from New York phone numbers were actually answered out of state. So this legislation that's being proposed will help to prepare for the transition by ensuring that the state has complete coverage by crisis centers in the Lifeline 988 network. 988 is not just a telephone number change for the Lifeline, it also represents a unique opportunity to change how the state delivers crisis services for our most vulnerable citizens. This legislation will move New York State from its current fragmented system to a coordinated, connected crisis continuum that leads with a mental health approach to mental health crises. Crisis counselors in the Lifeline network are highly trained to help people in emotional distress or suicidal crisis. For approximately 98% of answered Lifeline calls, the counselor is able to assist without an in-person response intervention. But New York State currently doesn't have statewide capacity, right, to provide mental health crisis response when individuals calling 988 need an in-person intervention. This response often falls to emergency responders, mostly law enforcement officials who aren't trained in managing a mental health crisis. And we've heard and we know all too often what happens when a non-mental health approach is used to respond to a mental health or suicidal crisis. Mental health crises may result in potentially dangerous and traumatizing outcomes when police are called, especially in historically marginalized and underserved communities. Despite their best efforts, 911 dispatchers and law enforcement officers usually have not received specific training on how to handle mental health and suicide-related calls. Senate Bill 6194 seeks to reduce these types of negative outcomes by promoting 988 as the resource for mental health and suicidal crises with well-resourced crisis centers that can connect individuals experiencing these crises with appropriate and compassionate care from trained, culturally competent responders. 988 also holds the promise of an equitable mental health response with better outcomes, but it needs to be adequately resourced. Senate Bill 6194 provides a sustainable mechanism by allowing for a surcharge on telecommunication lines. It's important that this surcharge should supplement, not supplant, existing funding and billing options. So we need to be looking at state and federal funding, public and private payers, in addition to this surcharge, which is vital for building crisis infrastructure and needed capacity. So as the nation faces unprecedented challenges, now is the time for bold, comprehensive, and dedicated actions to prevent death by suicide and ensure resources for individuals facing mental health challenges. So thank you again for the opportunity, and we urge support for Senate Bill 6194 and look forward to working together to help everyone achieve emotional well-being.
Thank you. Dr. Jeffrey, do you want to go now?
Sure. Thank you very much. So I really want to thank the chairs and the committee members for this opportunity to speak. I'm calling from Suffolk County, Long Island. I work at Family Service League, and we provide most of our services in Suffolk County. And we are we've been around since 1926, and we're the largest behavioral health provider in the region. In 2019, we opened up DASH, which stands for the Diagnostic Assessment and Stabilization Hub, and it is the first 24/7, 365 crisis stabilization center in the region, really treating those 5 years and older, substance use, mental health issues, or other life stressors. And importantly, the hub is just that, because connected to it is a continuum of crisis services. We have mobile crisis teams, and similar to what other people have been sharing, they are staffed in teams of a peer and a licensed social worker. We have a 24/7 hotline as well, and the three work in tandem. It is, if you're ever on site, it's a beautiful recovery-oriented, warm, inviting center. But there's the staff, it's palpable. The staff are cross-trained. They can go where the demand is at any particular time. We have a software application that we use that really ties all three components together. And not only from a data capture and reporting standpoint, but it helps to dispatch mobile crisis, for instance, from the hotline to DASH or to a mobile crisis team, and it really works seamlessly. DASH is unique in that we have all three components, the stabilization hub, mobile crisis, as well as the hotline, all under one roof. And it really allows for, individuals receiving the right care at the right time in the right setting.
What supports that? Like, in other words, can you bill for your services?
Yeah, so it's a great question. So it's really a prototypical program, and OMH, Oasis, and they're really using our program to replicate this model across the state based on the success.
Did you ever come to Orange County? I think you look familiar to me. And,
I don't think
and
so.
give a presentation?
I don't believe so.
Okay.
But it right now, and I'll just speak to your very specific question. It's a great question. I would say that I really, it's a braided funding model right now. What I always say is that it was very innovative at the time. As we know, the crisis regs have not been promulgated yet, and there is not a fiscal model that really supports what we're doing. So we took a risk because we're so passionate about what we do, that we are waiting for that bundled rate to come to really, ensure viability. So it's really a combination of state funding, grants, and various funding sources, and being as creative as possible to make sure we get, continue to do the work that we're doing. But I'd be glad. It's a $4 million budget with all those components, and we've been able to do it, with the support of various funding streams. So, I know that others have talked about linkage in the past, in terms of the importance of that. I think Steve mentioned that. And we pride ourselves on, when someone comes to the stabilization center, to make sure that there is successful linkage afterwards. So, just to throw out some numbers real quickly, in 2020, we engaged at the stabilization center, the hub itself, 5,000 unique individuals, 30% minors, 70% adults. We have a separate entrance for law enforcement. We partnered very closely with Suffolk County Police Department from the beginning of our planning stages. We anywhere from 5 to 10% of the people that come to us are from a voluntary police transport. We make over 300 linkages from ongoing aftercare mental health services per month, and 70 for substance use at various levels of care. We have handled 13,000 hotline calls for the year, and we engage in the community through our mobile crisis teams about 110 people per month. So we have scaled pretty quickly. We have met it was a long-standing gap in the larger system. So we knew that once this opened, that the trend that we're seeing that, the local, comprehensive psychiatric emergency program at the local hospital in Stony Brook, the trend since we opened has been downward in terms of their visits, and we're great partners with them, but it is absolutely working. It is a wonderful model in that regard, and very multidisciplinary.
So someone did you finance this or did the state finance it? So in like an area like Stony Brook, sometimes that, you look at income levels in different areas, and where areas like where you're able to create these kind of models because you have the support of, larger hospitals, you do have larger hospitals. So like your support, how did you like finance, like sometimes like in an area like mine in Sullivan County, it's an extremely poor, diverse area where we have diverse area, we have, a lot of issues, and it's harder for us to like kind of attract folks because many of our folks don't have insurance. So we try to hook them up whenever we can when we see them. But, Long Island is a wealthier area. So, do you go to areas that are like mine?
We have a very, who we serve is very underserved, so to speak. As I mentioned earlier, we're the largest behavioral health provider in the region. So we have 7 mental health clinics outside of our DASH program, 3 chemical dependency clinics, but we're in, Brentwood, Bayshore, Central Islip, Riverhead. So 50% of the people that we serve in DASH are Medicaid. And then the others are comprised of, commercial insurance, self-pay and the like. So, the follow-up is key. And I mentioned the software application that we use, a proprietary program that was developed by, people in this space, in Georgia. But we are able to use shared calendars. We are able to plug people in with aftercare appointments before they leave DASH, whether it's one of our clinics or one of our sister agency clinics. We definitely are harnessing technology to make, to make this program as effective as possible. We are going to be part of the 988 network, and we are doing some exciting stuff with the police department. In June, we are embarking on a 911 diversion program. Suffolk County has a huge law enforcement, force. And we are, right now, the officers in the dispatch or the call center are being trained, and they are going to determine who meets the eligibility criteria so there can be a warm transfer from 911 to our hotline. And
I'm sorry, your time is up, and I don't want to cut. I have to cut you off because I cut everybody else off. But thank you for your. I don't know, Harry or Senator, do you have questions?
Yeah, sure. Thank you so much for going through. I think this was a good sampling of what programs look like now. One thing that I'm curious about to hear more of is we've talked a lot about recruitment and retention for staff, and I'm very interested, in the fact that you have a 24/7 center. How do you recruit and retain staff in those scenarios? And I assume these are all paid staff and it's not necessarily using volunteer force.
It is paid staff. So you hit on one of the 2 challenges, but, I think our reputation, in part, helps us from a recruitment and retention standpoint. Since opening, we have, become pretty well known within all the school districts, because rather than children being brought to the ED, in handcuffs by the police, a lot of them will come to us for risk assessments and school clearances. But I think, just, the organic nature of how everyone knows about DASH now, and people want to work there, and we have a crackerjack staff. They are so mission focused. So passionate about what they do. And like I said, it's an interdisciplinary team, and it really has a sense of cohesiveness that it's somewhat sought after in terms of people wanting to be there. But not, all that notwithstanding, there are some challenges in terms of just finding enough of a pool of social workers or other providers because I think we're all experiencing a dearth in that area.
Thank you.
If I could just add to that quickly, it's about how you train your staff as well, and how you're really, it's a common sense approach to care, but it's also outside the box of traditional systems. And we really put a lot of work into our staff training, as well as self-help supports and supporting the staff through, the difficult work that they do. But it is a different level of compassion and passion that the staff have in the stabilization center.
Thank you. Christina, would you give us any advice, since you're come from an opposite point of the business owner, but somebody that has been involved involved. So I think that your advice would be welcomed here from both the senator and I.
Thank you so much. Thank you.
What we could do to make it better, I guess.
So, their studies show that there's only 4% of Black psychologists that represents for the whole 12 to 13% Black population in America. So there's obviously a shortage of culturally competent care. My suggestion is somehow, if you can incentivize people in the communities of color, whether it's a full-time scholarship to a city school, to go back to school for some kind of mental health professionals, because I'm not to become mental health professionals, so they could be able to provide the services, quality care services that are culturally competent within their community.
Thank you. And thanks to all of you for participating today. Both the senator and I are available. If you have any legislative or any suggestions for us, we're always available. Is that okay if I say that, Senator?
Of course. I've had the pleasure of being in touch with some of you. I would love to continue that. And I know that we also have Assemblymember Bronson that had his hand up to ask a question.
Okay, sorry, Harry.
That's okay. Thank you so much. First of all, Christina, thank you for sharing your life's journey.
Thank you.
And that it's so important for us to hear that because it helps us better understand, even though we probably never will fully appreciate what you have gone through. My question for you, though, is as a peer who's been helpful in these types of crisis responses, what do you think we need to do to make sure that peers are equipped and they're ready to put themselves out there to be helpful with someone who is having a mental health crisis or a substance use crisis? And then also, if you're familiar with Daniel's Law, the proposal, if you could also comment on how you see peer advocates and peer folks being part of the regional councils and moving it forward.
Now, for any job, my opinion is that it's important to hire people who want to have that job, who are capable, who are compassionate. Not every person who is a peer is compassionate, just like every doc, not every social worker is compassionate, every police or whatever. It depends on the individual. Secondly, I feel that the peers, even though a lot of us do have empathy, like myself, even though I do have some training in crisis response, because I did take the CIT training program at NYPD and the Department of Corrections, I think training is important. Like with the Hoots model, I think it was like 500 hours of training. So definitely get the people trained, do the scenarios, and make sure they're equipped. And also have the supports where there's a peer specialist supervisor, not a social worker, but a peer specialist supervisor who is equipped to give the support and counseling to the person if the person themselves who are giving the supports need someone to talk to and, care, adequate care. And what was your second part of the question? Is that helpful?
If you're familiar with Daniel's Law proposal, how you saw the peer approach fitting in with what is proposed in Daniel's Law?
I think the peers should be definitely, I'm not really familiar with Daniel's Law, but I think the peers should always be part of, in any type of proposal or legislation, peers should always be part of the planning, the design and implementation of everything that's related to mental health, because there's nothing about us without us. We know exactly what we need to do on the ground because we work on the ground every day. We know exactly what our communities, how they think, walk, and talk like. We know exactly what the supports and services that they need because we've been doing it by ourselves. Does that help so much?
Absolutely. Thank you,
Thank you
Christina.
very much. And now we're going to go to the next panel. We appreciate all your time. I know the senator and I and Harry, he's our third, the three of us are available. You can find our numbers if you have any suggestions, or, you know, if you have anything we can do to help you, don't hesitate to call. Thank you so much. I know you waited a long time.
Thank you.
The next panel, panel 6. Is Patrick here?
Yes, I am.
Patrick has requested to go first, so your request is granted, Patrick.
All right, thank you very much. I do want to mention, as I start, that I may not be able to stay for the full discussion of this panel. I have a hard stop at 2:45, but I will stay right up until that time to participate as much as I can.
Thank you, Patrick.
And thank you to you, Chair Gunther and Senator Brooke and Assemblymember Brunson for the opportunity to testify at this hearing. And I also want to thank Assemblymember Brunson and Senator Brooke for their leadership and for the legislature's attention to this important issue. It's an honor for me to represent the University of Rochester Medical Center in our Department of Psychiatry today to share some thoughts about how state government can better support New York families coping with mental health and substance use challenges. I was glad to see the scope of this hearing broaden from its initial focus on crisis response. All of us on the front line of patient care would encourage our state leaders to take a holistic approach rather than a piecemeal approach to mental health and substance use disorder services. We think effective solutions must address 3 closely linked components of the challenge: preventing crisis, expanding inpatient care, caring for people in crisis. Addressing the first 2, prevention and expanding inpatient care, will help to reduce the frequency of crisis intervention. Unfortunately, across our behavioral health support network, including health systems, community providers, social service agencies, the needs in all 3 areas are outpacing our ability to meet the demand effectively. For prevention, patients need care that is physically and financially accessible. Services need to be well-staffed with clinicians, providers, peer specialists, community health workers, family advocates, and others who help people build resiliency and address problems. Last summer, URMC opened the City of Rochester's largest outpatient mental health service center, a new $4 million clinic on Chestnut Street that makes many of these resources more accessible for our urban patients and families. However, low Medicaid reimbursements impair the ability of clinical programs to recruit and retain clinicians to meet the demand. At URMC, and especially at the community agencies we partner with to provide comprehensive support for our patients. Recruiting and retaining clinical staff is a major challenge across the state, in rural communities as well as underserved city neighborhoods. Inpatient capacity, which has steadily declined over the past decade, is another challenge the state could help us address. The reduction in state-run psychiatric units has led to a vicious cycle for many families. Symptoms worsen as patients wait for admission in overcrowded EDs, leading to longer hospital stays, which further limits access to care for others who need it. Another challenge is finding appropriate options when patients are ready for discharge, such as residential treatment or safe housing. Finally, the state can help communities respond more effectively to people in mental health and substance use crisis. That need is painfully clear in Rochester, where we have witnessed the deaths of Daniel Prude and Tyson Jones over the past year. We thank Assemblymember Brunson and Senator Brooke for introducing Daniel's Law. It recognizes that someone experiencing a crisis deserves a mental health response, which employs actively listening, validation, and therapeutic interventions to de-escalate the situation, followed by linkages to services that address their long-term needs. To support solutions like these, URMC operates a crisis call center and a mobile crisis team that work around the clock, 7 days a week. We've been actively engaged in efforts to strengthen our community's response to people experiencing a mental or behavioral health crisis through the Race Commission, the Monroe County Mental Health and Substance Use Disorder 90-Day Task Force, and ongoing collaborations between health systems, emergency medical services, and law enforcement. In addition, we convene our own behavioral health task force to enhance crisis services internally. Each week, we meet with the leaders of all the programs in our community that provide crisis services. The purpose is to collaborate, communicate, and develop a system of crisis response that meet the mental health crisis needs of our community more effectively and efficiently. As Daniel's Law is finalized and implemented, we encourage you to consider strengthening and expanding existing resources and structures that are effective across regions of the state. Thank you again for the opportunity to testify. And we'll be submitting a more detailed written statement for the panel.
Thank you. So, Dr. Mary? It's my daughter's name.
Not many Marys anymore. Anyway, thank you so much for this opportunity to address the New York State Joint Senate and Assembly hearing on mental health crisis services. My name is Dr. Mary Morocco, and I am the Medical Director of Acute Services at Rochester Regional Health. We are the largest provider of behavioral health services in Western New York. We provide services across the lifespan in both substance use disorders as well as mental health. We provide crisis intervention, inpatient, outpatient, community-based services for children, adults, and families. We serve individuals in both urban and rural communities. As a psychiatrist who has dedicated my career to acute services, including crisis intervention, evaluation, and dispositional planning, I thank you for the opportunity to speak to this, as well as to speak on behalf of Rochester Regional Health. When an individual looks to access acute services, they're looking for a response from someone who has assessment skills, who has the ability to identify current needs, to de-escalate, and to somebody who's familiar with the community resources and are able to access those resources readily. During today's joint session testimony, people may try to answer the question, who should respond to a circumstance in the community in the event that a behavioral health crisis is occurring? The short and simple answer is, it depends. Because crises are variable and individual needs are variable, the responses need to be variable as well. In Rochester, we have several different crisis outreach teams. We have some that work with law enforcement, like the forensic intervention team, and we have several that are diversions from law enforcement, including the recently formed Person in Crisis team, as well as our own Rochester Regional Behavioral Health Access and Crisis Center outreach team, and as was mentioned earlier, Strong Memorial Hospital's mobile crisis team. We also have a team that works in a more urban area in our eastern region. Because in a rural area, the geographical challenges occur where the crisis intervention worker and the individual in crisis may be far apart, we implemented a program where law enforcement has an iPad and they can access the crisis worker in real time, who can assess the situation, de-escalate, intervene, and set up follow-up without the person ever having to leave their home. As we look at New York State's plans for a crisis intervention service delivery system, there are some key components that must be reconciled in order for this to be successful. One is integration of mental health and substance use disorder services. In the past, we've seen siloing between OASIS and OMH. And in order for us to better meet the needs of the individual in the community who may be having crises involving both mental health and substance use, we have to reconcile those both funding and regulatory issues. The second is financially viable funding. I think I've heard other people talk about this. We need to be able to have funding for crisis services. At this point, we're funded by grants, deficit funding, and a portion through traditional billing, but sometimes we try to put a square peg in a round hole with regards to looking for ways to bill for services that there are no current billing codes available for. Also, telehealth. The pandemic has catapulted us into the 21st century with regards to telemedicine. We have seen significant increases in the use of telehealth, both telephonic and televideo visits. And we're surprised that we actually had a 10% increase in completion of appointments through telehealth interventions, which in a way isn't surprising, given that if I lived in the city and had to take 3 buses to get to an appointment and there's 2 feet of snow on the ground, I'm probably not going to make that appointment. So this allows us to reach individuals better. We need timely availability of services by a multidisciplinary team that can provide for a multifaceted population. And we need community engagement. And the service has to be the individual's choice. Relationships with the community that we serve will increase engagement and credibility. And this, we look to increasing individuals with similar racial, ethnic, and experiential backgrounds. With that, I'll complete my testimony, and I thank you for your time.
I keep forgetting to unmute. So would you like to go next, Corinda?
Yes. So
thank you so much. You waited a long time. I'm sorry.
That's okay. I actually sat through all the testimonies all morning and all afternoon.
It was pretty enlightening, eh?
Yeah, absolutely. Unfortunately for all of you, some of what I'm going to say is going to be a repeat of what you've heard.
That's okay. You waited. We're willing to listen.
Okay, so I appreciate you inviting me this afternoon. I'm Corinda Crosdale, Deputy County Executive for Health and Human Services in Monroe County. And I'll be speaking specifically about our forensic intervention team. And if I have time, I'll touch on the 90-day task force that Patrick mentioned earlier. So our forensic intervention team, also known as FIT, is housed in the Monroe County Office of Mental Health. It promotes and administers programs and services for Monroe County residents who require vital supports to help address needs linked to behavioral health and substance use disorder. In carrying out the department's mission, the Office of Mental Health provides leadership and direction to an integrated network of 70 county-based providers who administer over 300 programs designed to serve and help empower individuals and families in need of treatment and other support services. Launched in 2017, FIT works in collaboration with Monroe County law enforcement agencies, partnering FIT mental health clinicians with officers. They provide effective and compassionate crisis intervention for individuals in our community who have frequent contacts with law enforcement due to diagnosed behavioral health concerns. The objective of FIT is to connect the dots for individuals who engage with law enforcement, clinical systems, court systems, family systems, and as you've heard today, non-traditional supports. By linking to the appropriate systems, the desired impact is the reduction of calls for emergency services, increased connections to services and supports, and lower instances of crisis situations. This model allows law enforcement agencies and FIT clinicians to work together with the common goal of providing the best options for individuals diagnosed with mental health and substance use disorders in our community. Currently, all FIT forensic specialists are available 24/7 to receive referrals directly from law enforcement or 911 dispatchers, serving as a primary point of referral and triage to link individuals with mental health resources. Monroe County Office of Mental Health has a collaborative partnership with community treatment agencies with commitment to accepting FIT referrals and rapid access to care. FIT has proven to be an asset to our community, and I would be remiss if I didn't recognize the hard work of our dedicated team who has gone above and beyond. The Monroe County team, in partnership with many of our dedicated providers, continue to be proactive in working to improve service delivery and advocacy for those in need of behavioral health and substance use disorder services by increasing partnerships and integrating our work with other agencies and entities to maximize the utilization of resources. My understanding of the importance of integrated services go beyond my role as Deputy County Executive, having started my career working with individuals who were chronically homeless and seriously and persistently mentally ill. Much like the program I'm speaking about today, my goal was to ensure linkages to the appropriate community services. However, as opposed to reducing the frequent intersect with law enforcement, I sought to reduce the intersect with homelessness. I entered this system and have remained for over 2.5 decades to be an advocate for those who don't have a voice, to empower those who are underrepresented, to see their strengths and connect them with resources to help them achieve their goals. So I'm extremely grateful for the opportunity to share in the advocacy for effective approaches in addressing the challenges connected to behavioral health and substance use disorders, particularly given today's environment of COVID and social isolation. Keeping these issues in the forefront will only serve to strengthen our delivery systems. With the remaining time, yes, I'm sorry.
I'm sorry to interrupt, but I was going to ask you, over the years, you seem to be doing it for a long time. Have you kept statistics about decrease in emergency admissions to the hospital, also cost savings, those kinds of things?
Absolutely. It's usually done by a program to program basis. I think where we often miss the boat is on systemic changes. So when hearings like this are held, I get really excited because I really believe that statute and regulations and how that's structured impacts those statistics that you're talking about.
So Corinda, one of the things I would ask you is that, you know, I used to do policies and procedures for like a hospital, and the best way to do it is to like reach out to someone like Patrick or Dr. Mary or yourself, and in order to change it and make it viable and workable for you, it has to come from down here, not up there. So if there's a piece of legislation, and I don't know if you agree with me, Senator, but I think that we would be very happy to get your input on something that you would feel would create more efficiency and efficacy in the future. And I think that, you know, I has written a lot of policies for the hospital that I used to work in. You know, we used to go to the unit and find out exactly what they're doing, because you don't want like false policy that doesn't work for anybody. So I would be interested in, if you contacted either one of us, you could find our name. If you think that there's a policy that we possibly could change that would make it easier, but also would make it so to improve the quality of care that we're giving to people that come to your doors or that have been incarcerated, those kinds of issues, that if we could stop it from happening and we could provide care and like continuity of care, especially in terms of medications and you know, observing the reaction of the patient. It's just not there in a lot of communities.
I would welcome the opportunity if you all would be interested in maybe pointing to some specific legislation. As Dr. Mary mentioned, it's really a disconnect between the state agencies, and some of the legislation, the actual law, creates barriers for us with regard to service. And Dr. Mary talked specifically about OASIS and OMH. I would introduce in that OTDA, how we deliver those services, particularly with inpatient for substance use disorder. We find a lot of barriers because one law allows for the service delivery to happen like it should, and another law blocks it.
Well, I would welcome your help in any way, because, you know, I'll let, I don't know if the senator wants to chime in.
I appreciate that. And thank you all to everyone on the panel. Obviously have very close working relationship with many of the folks on this panel, having been in our community. And Corinda, thank you again for all the leadership you've shown in on the county level, which I think has really taken strides since you've taken over. So yeah, you know, I think let's continue. I think there's much to be done. As you know, our state delegation has worked with a lot of the local institutions around getting our arms around what this looks like. and seeing what we can learn to take statewide as well. Obviously, it's concerning anytime you talk about there being things that can't be reconciled if one if one statute or law says to do one thing and things are contradictory, that can make it really, really tough for folks on a local level trying to do the right thing by their communities. So that's certainly something that we have been collaborating and will continue. And I'm so glad that you were able to come to this hearing. So thank you for taking the time and for listening to all of these panels throughout the day. And so I won't take any more of my time. I know the clock just started for me, but I'll actually hand it over to our other Rochester delegation member, Assemblymember Bronson, because I know he's got some questions.
Thank you, Senator. So, Dr. Mary, I was going to ask you and Patrick this question. I noticed Patrick indicated he had to step off and had a hard stop. But for regional health, we talk about the emergency mobile crisis intervention, right? And then we have a stabilization period, and then we have long-term treatment, okay? So if someone comes to your emergency room and so they're in crisis, they need immediate services and responses, whether it's a mental health crisis or a substance use crisis, right? What procedures, what mechanisms do you use to then, beyond stabilizing them, then getting into some interim care and then ultimately long-term care?
Absolutely. Our first goal is to try to avoid that emergency room visit. And we talked a little bit about the mobile outreach teams that we have, but we also have our Behavioral Health Access and Crisis Center, which came out of a district project to decrease avoidable ED visits. It's akin to a brick and mortar psychiatric urgent care center. So it's an outpatient level of care, not an inpatient level of care, not a hospital level of care. So we hope to direct individuals to that center as opposed to the ED. If they do end up in the ED, and many do, and sometimes it's transportation related, they can take an ambulance to the emergency department, but may not be able to get to the crisis center. In any event, we assess, we look at what interventions will be the most therapeutic and at what level of care they can best be treated. Now, some will require inpatient admission, and Patrick had mentioned, this population that cycles through inpatient units who are very, very sick and who used to be on the inpatient units at the state hospital for a longer period of time. Now, some people live there, and that probably wasn't a great quality of life. But the reality is that there are some people for whom 7 to 10 days on an inpatient acute unit is not long enough. So for that population, they may be admitted, they may stay a little longer, or they may be in this revolving door of ED visits, inpatient stays, discharges, stopping their medication. Another population is the population that we can intervene with in this crisis and then continue to hold while we hand them off to the next level of care. And our crisis center does just that. We will have them go to our crisis center for a follow-up appointment from the emergency department. We use our crisis center for priority access appointments so that they can continue to do outreach for those individuals. If they say don't make it to the appointment, they can go to their home and they can see them in their home. We then will hand them off to the next level of care, which could be our PROS program. It could be an outpatient program. It could be medication management. But we try to have a warm handoff to the next level of care, which will increase the engagement of that individual and the likelihood that they will be successful in their recovery.
Thank you, Dr. Mary. And if the chairs will indulge me, I do have one question for Corinda regarding the FIT program. So you mentioned, Corinda, the mental health clinicians that are part of the team. What's the discipline? Is it only social workers you use? Do you also utilize the services of mental health counselors, family therapists? I mean, who do you have on these teams as mental health clinicians?
Most of them are master level social workers. The vast majority are licensed. Those who are not licensed are getting their clinical hours so they can sit for the exam, but
Okay,
master's
thank you.
level clinicians.
All right,
I
thank you.
think we have to move now, Harry, to the next panel. We have two more panels and they've been waiting patiently. I want to thank all of you and I'll let the senator finish.
I'm all set. Thank you so much. We can move on to our final panel, I think.
No, we have 7 and 8. Don't we have it? We
Thank
have
you.
it. I think we have 8 too.
Thank you.
Thank you, Assembly Member. So the next panel I have has Rosa Gill, Alice Buffkin, William Getman, Alicia Scovera, and Janine Mendez on panel 8. Fantastic. Rosa,
Okay.
why don't you start us off?
Good afternoon, Assemblywoman Elaine Gunter and senators. Thank you so much for
Dr.
inviting.
Rosa.
Yes.
Hi, how are you?
How are you? Good to see you again.
Good to see you too.
I'm delighted to be able to participate and provide comments on an important bill, 6184. And thank you so much for that invitation. I'm here to highlight the challenges of the impact of coronavirus that has been a breeding ground for a mental health crisis that has raised unprecedented levels of risk to the Hispanic community. The New York State Office of Mental Health reported that at 42%, the Latino community has had the highest rate of anxiety, depression during COVID in comparison to the other ethnic and racial groups in the state. Regretfully, at 34%, New York City Hispanics have had the highest rate, mortality rate of any underserved community. The CDC, the Youth Risk Behavior Survey, released in August of 2020, reported that in 2019, 18.5% of Latina teens in high school seriously considered, and 10% almost attempted suicide in New York City. For 13 years, Community Life, the Life is Precious program, has been provided after school suicide prevention activities to over 400 at-risk Latina teens in New York City. Assemblyman Goddard, I want to reassure you that during those 13 years, we have saved a lot of money by preventing unnecessary ER presentation and admissions to hospitals. However, and we understand that there have been a long understood that there is deeply entrenched issues that resulted in an increased mental health disparities for Latina teens. The COVID-19 pandemic has really brought this issue to the surface and has widened the gap in the need for culturally and competent linguistic mental health services for the Hispanic community. Since the start of the pandemic, in the last 13 months, we have provided to our risk Latina teens over 7,000 individual and group case management sessions, remotely of course, over 600 sessions of individual group tutoring and test prep. We have worked with the parents in groups to be able to sustain them through this crisis. We have worked with case managers and teachers and school counselors. We have, of course, have a lot of coordination with the mental health clinics that have been servicing these Latina adolescents. Despite all this intervention, assemblymen and senators and distinguished colleagues, despite all this intervention, the impact of COVID on our Latina teens and their family has been devastating, as evidenced by the fact that for the first time in 13 years, we have already 14 admissions. I said again, 14 admissions to child and adolescent psychiatric inpatient unit by 11 Latina adolescents in our LIP program. And those admissions were due to severe suicide ideation and attempts, including one teen who has been admitted to an inpatient psychiatric program 3 times since December. She is currently hospitalized at Westchester Child and Adolescent Psychiatric Unit. I want to highlight that the majority, 84%, of all these psychiatric admissions have occurred since December 2020. Unbelievable, in the last 5 months. To ensure that Latina teens receive the support they require, we at the Life is Precious program have developed categories to rank the teens high, medium, low risk, and so forth and so on. I want you to know that we currently have 20 Latina adolescents at risk of suicide as we speak. And this is an unbearable situation for these families and these parents. I'm here to support the bill, but I'm also here to say that the State Office of Mental Health is the mental health authority in the state of New York. And really, if we really believe that there is a zero suicide in the state of New York, then I think that we have to create like SWAT teams and really impact on the stressors of this family. And the stressors of this family, I'll tell you in a minute why. 83% lost their job, 53% lost families to COVID, 70% are undocumented. So when they lost their job, they cannot get, unemployment. So 100% experience food insecurity. These social determinants of health have created this crisis that needs to be dealt with. Programs need to create it. The State Office of Mental Health have to really create and fund comprehensive family home-based intervention for these Latina adolescents and at risk. Just to underline the problem, just 2 weeks ago, one of our Latina teens, her brother, 28 years old, he jumped out of a window in the same apartment. And that kid didn't even want to come out of her apartment because she said, I'm going to step on the blood of my brother. So I'm here to obviously support this bill, but I also want to underline that there has to be a response to the crisis of Latina adolescents and their family in New York State. I just want to say that regarding the 899, the Latino community has a great hesitancy to use a phone to talk about the crisis. They don't do that. They really need you at their home to talk to. So yes, we will support this bill, but we want to make sure that there are sufficient bilingual, bicultural counselors only on the line to respond to the need of the caller, the Hispanic caller. Furthermore, we want to be sure that there are sufficient outpatient mental health clinics and other services available to meet the need of the callers. Thank you so much, and if we can help in any way to support this bill, we will. And please help these Latina adolescents and their families at crisis. We don't want them to die. Thank you so much.
Chairman Gunther is muted, but I think she was also saying thank you. So I will introduce our next person, Alice Bufkin.
Thanks so much. My name is Alice Bufkin. I'm the Director of Policy for Child and Adolescent Health at Citizens Committee for Children, a multi-issue children's advocacy organization dedicated to ensuring every New York child is healthy, housed, educated, and safe. I'm also here on behalf of the Healthy Minds, Healthy Kids campaign, which is a statewide coalition of behavioral health providers, advocates, and family organizations committed to ensuring that all children and adolescents in New York receive the behavioral health services they need. I want to thank Chair Brook, Chair Gunther, and Assemblymember Bronson for holding this critically important hearing. Throughout today, we've heard over and over about the toll that COVID-19 has had on the mental well-being of New Yorkers, including so powerfully from Dr. Gill just now, but also the existence of deep unmet needs and fundamental access barriers that existed prior to the pandemic. Nowhere is that more evident than with children and adolescents. While suicide is the 12th leading cause of death in New York, it's the second leading cause of death for children 15 to 19, the third leading cause of death for children 5 to 14. That was the case before the pandemic. With COVID, we're seeing a generation of children who've lost loved ones, who've been thrown into poverty, who've lost their housing, who've faced anxiety and isolation for over a year. All of these challenges are disproportionately impacting low-income communities and children of color. As children's behavioral health needs have skyrocketed, their ability to access services has been severely impaired. The result has been fewer children accessing preventive services and more children showing up in the hospitals and ERs in severe psychiatric distress. Data from the CDC showed a 24% increase in children's mental health related ED visits for children aged 5 to 11, and a 31% increase for children 12 to 17 during the peak of the pandemic. This is also what we hear from providers and partners on the ground. More children are coming in at younger ages with more severe needs, including attempts at suicide, kids who are going without care, ending up in hospitals and ERs, and hospital beds are full. And I say this all not just to underscore the crisis that children and their families are facing, but also to point out the fundamental and essential relationship between preventive services and crisis needs. If more children receive the services they need earlier, we would not see so many increasingly young children present at emergency rooms with thoughts of or attempts at suicide or other severe needs. We can't expect to address the mental health crisis delivery system without, one, addressing the lack of adequate preventive care that leads to these instances of crisis, and two, without addressing the dearth of clinical care options across the continuum, from school-based clinics to community-based treatment to hospital-based interventions and step-down care. We really are failing a lot of our children and their caregivers, and what we do now will impact them for a lifetime. So the urgency really can't be overstated. And I know the reason this call is happening is there's a real understanding of that. With that ground set, I want to offer a few recommendations. First, we need to invest more in the full continuum of care for children. Historically, children have always received a fraction of overall behavioral health funding in the state. This only results in children going without adequate care throughout their childhood and then becoming adults with even more heightened and multifaceted behavioral health needs. We must shift this paradigm and disrupt this cycle by investing more funding upfront for children and families. We have one opportunity to do this right now through new federal funding coming to the state, including the $46 million through the Community Mental Health Block Grant, as well as a 10% enhanced FMAP for HCBS and rehabilitative services. We join many other partners in urging parity in how OMH distributes this funding. Children should receive half of any new federal funds coming into the state intended for the behavioral health system. In terms of specific items raised today, we strongly support legislation to enact Daniel's Law. More broadly, we do not believe police should have any role in responding to mental health crises when they involve children. We also support the establishment of a 988 suicide and mental health hotline. We believe this, coupled with an expansion of the workforce, can make a meaningful difference in crisis response. We also strongly support the expansion of mobile crisis teams and alternatives to crisis removal that are trauma-informed. In terms of crisis stabilization centers, we do not believe that these can be considered part of the children's system without complete and thorough engagement of the children's behavioral health field to ensure that centers are designed as child and family appropriate. Children and families do have very unique needs. The National Council for Behavioral Health's roadmap to the ideal crisis system is a really important resource, but so are the voices and experiences of families and providers in the state who are best able to speak to community crisis response for young people. All of our efforts to invest in crisis response will do little if we're not also investing upstream in a full continuum of supports for children and their families. So I will include additional details in my written testimony, but I want to touch on several areas that do require urgent attention. New York must integrate services for young children and their caregivers into pediatric and other young child spaces. We need to invest in culturally and linguistically competent services, invest in wraparound and clinical supports in schools, make significant workforce investments, which I know was addressed earlier today, to address the widespread and chronic provider shortage in the state, and to expand clinical capacity throughout New York and invest in a wide array of services that support children and families holistically, including family and peer supports and community-based services. We also need a fundamental reexamination of our Medicaid redesign system for children's behavioral health. Services like children and family treatment and support services should be available in the Child Health Plus program as proposed in Assembly Bill 303B and 2539B. However, we also believe a course correction may be necessary to ensure that children have not experienced a decline in services following redesign of the Medicaid system. New York must also invest in telehealth services and parity. and at the same time work on addressing the digital divide and ensuring equity in how services are accessed. So just in final seconds, I just want to again express my real appreciation for holding this hearing and for addressing these critical needs, and for everyone who spoke today.
Thank you so much, Alice. William Getman from Northern Rivers Family of Services.
Thank you, Senator. Chair Gunther, Member Bronson. My name is Bill Getman. I'm the CEO of Northern Rivers Family of Services. I'm speaking today on behalf of kids and adults because at Northern Rivers, we provide services in education, foster care, and most importantly, mental health services for young people and adults. We operate 3 clinics. We operate a youth ACT team or an ACT team. We operate specialized programs, including residential care. I want to congratulate you and applaud you for your leadership today and your passion and your energy, because you've assembled a great group of people here with brilliant ideas. So we need to find a way to pull them all together and integrate them into a new system for crisis services. It is a critical time, as you've all said, for the reform and the delivery of the system. And I want to offer some specific recommendations in that regard. First off, I think the enactment of 988 will be a powerful tool and give us the sustainable funding that we're going to need as we implement new reforms. As Alice just said, we also need to take advantage of the FMAP money and the federal money coming to New York State. And I have some specific ideas in regard to workforce. If and when we have a sustainable and well-designed crisis stabilization set of centers across New York State, we need to architect and design them from a common sense perspective. As been pointed out many times today, we need to not build bricks and mortar facilities. We need to invest in upstream services that prevent some of the crisis that puts kids and adults into a bad place. We recommend the expansion of mobile crisis services across the state. As a provider of 5 different mobile teams in our region right now, I can underscore and amplify mobile crisis services work. They keep people out of hospitals, they keep them out of harm's way, they keep them away from law enforcement. We need to expand it 24 hours a day, 7 days a week, and it can't be a patchwork. We need to enhance other intervention services, including the CFTS services that were planned to help the children's system 7 or 8 years ago. That realization has not occurred, and if we don't invest in these services, they will fall apart and we will have more crises. We need to expand CIT teams, and as you heard many times today, we need to invest in peers. We need to double down our investment because peers make an impact across our state. Mental health first aid and other strategies have been proven to work in our system, and we need to expand that. And I want to put a plug in, obviously, for the veteran peer support and other options that are upstream interventions. But having just said all that, and I think we have an opportunity and we have resources, none of this will come to fruition if we don't invest in our workforce. We have a crisis. You've heard it all day. Assemblymember Bronson, Senator Brooke, you're sponsoring the licensure bill. That if that doesn't pass by June 24th, we're going to lose thousands and thousands of licensed clinicians in this state. We won't be able to do mobile crisis. We won't be able to provide enhanced services. Clinics will have wait lists that will be out the door and around the block. I hate to say this, but at Northern Rivers and our 3 clinics, we have a wait list of 1,000 individuals. We would need to bring on board 50 staff right now just to care for those individuals. They don't exist in New York State. So we need to pass the licensure bill, and I appreciate your leadership on that and all the pushing you're doing. We also need to invest in the workforce. We need to use our FMAP money and our federal relief money to do bonuses, debt and loan repayment for our clinical staff, and other innovative ways to reduce the turnover. Turnover at 35 or 40% is just deadly to our field, and it's not fair to clients. Last and not least is we need to get back into our schools now that they're going to reopen in the fall, and we need to support and expand mental health services, because putting clinicians in schools and building a network with social workers and guidance counselors and teachers is a good primary prevention effort, and that keeps the crisis system from exploding. So I think we need to use this money wisely, and I think you've got some great ideas, and you've got 8 panels of really smart people. So thank you for holding this hearing. your passion and your leadership is duly noted. And yes, we got to pass the licensure bill. We got to get it done. We got to push it over that line. So thank you very much for your time and your leadership, and we're here to help.
Thank you so much, Bill. I appreciate that. Next, we have Alicia Escovera, Director of Camping and Year-Round Programs.
Good afternoon, and thank you so much for the opportunity to testify. Assemblymember Gunther, Assemblymember Bronson, and Senator Brooke. I appreciate this opportunity. I'm Alicia Scovera. I'm here representing the New York State Camp Directors Association, which includes over 125 New York State camps. I also want to highlight an important piece of legislation sponsored by Senator Brooke and Assemblymember Avenanti. The measure would allow children's summer camps to hire licensed mental health professionals. It has already passed the Senate several times, but has failed to move out of the Assembly Higher Education Committee. I am also here as my role at the Fresh Air Fund as a senior director and a 15-year tenure. I've seen firsthand the need for continuing mental health services to our youth while they attend camp. At the Fresh Air Fund, every one of our over 3,500 campers fall below the poverty line, and many of the over 600 staff that we hire are alumni of our programs. More than half of all the children we serve come from a New York City neighborhood associated with high risk levels for child well-being. 1 in 6 has an emotional, behavioral, or learning challenge. 1 in 5 has asthma, and 1 in 20 is in foster care, is homeless, or is living in a temporary housing or shelter. In the summer, and almost on a daily basis, we are faced with mental health challenges like eating disorders, depression, anxiety, self-mutilation, and sadly, have come firsthand with young people trying to commit suicide. All of these were issues that we saw before the pandemic. To now add social isolation, limited physical activity, and the difficulty that our communities are having in accessing health services normally provided at school, we know that all of these will really amplify the negative impacts on child well-being. New York camps already hire doctors, nurses, and nursing practitioners to care for children, but their mental health is left unaddressed. Children who receive services during the school year have to get cut off from those services once camp starts. And all of our neighboring states, Connecticut, New Jersey, Pennsylvania, Massachusetts, Vermont, all allow licensed mental health providers to be hired at their camps. You have been steadfast leaders in the fight to address issues related to parity between physical and mental health services. I urge you to continue your leadership and afford camps the opportunity to provide comprehensive care that addresses both physical and mental needs of our youth. The New York State Camp Directors Association has worked diligently, actually since 2013, with the Assembly and the Senate to craft an acceptable bill to the Assembly Higher Education Committee. The time is now to pass this bill. The Senate has already passed it several times, as I've mentioned, and as a child advocate and one who is worried about the mental health of children, now more than ever, we implore you to allow camps the ability to hire licensed mental health providers. I certainly am so appreciative of your time. Thank you for taking this under consideration, and I'm happy to answer any questions that anyone has.
Thank you so much, Alicia. Our final panelist for the day and also on this panel is Janine Mendez. Go ahead, Janine.
Yes, good afternoon. My name is Janine Mendez, and I'm actually testifying on behalf of Yvette Bayran, our Chief Executive Officer at Astor Services for Children and Families, serving both the Mid-Hudson Valley and the Bronx. Thank you for giving us this opportunity. Since 1953, ASTA has provided critical services for over 10,000 vulnerable children and their families annually, primarily from our Black and Latino communities. These children, adolescents, and teens struggle daily with emotional, behavioral, mental, and psychological problems, often experiencing debilitating isolation and anxiety, which has been further exacerbated because of the pandemic. I want to share some stats with you. Since shifting most of our services to telemental health in March of last year, we provided 167,109 telemental health sessions. We have admitted more than 4,100 new clients, and we have seen a 40% increase in suicide attempts at Astor. If you have any doubts of telemental health, in recent months, we had 2 suicide attempt cases that played out via telehealth session and were successfully de-escalated by mental health counselors. One child in the roof of their apartment building and the other in a bridge. So with our colleagues, we really do appreciate your assistance and really need your help with the following challenges. We support investing new block grant funding into crisis services and would be remiss not to mention how severely underfunded the Medicaid redesign has been for children's mental health services and how bitterly disappointed we are that 1% COLA will not accrue to the newest children's community behavioral health services like home and community-based and children and family treatment and support services. Based on those disappointments, we urge that no less than 50% of the new block grant funding be invested into shoring up the failing Medicaid redesign for children's behavioral health, integrating additional services for youth with both mental health and intellectual developmental disabilities, and easing restrictions on eligibility for the newer services for youth with addiction disorders. Gaps in children's service delivery have emerged since implementation of redesign, and we ask that the new federal funding be used to shore up the problems and fill in the gaps. In terms of crisis stabilization centers, we do not believe that these can be considered part of the children's system without complete and thorough engagement of the children's behavioral health. We seek investment in evidence-based and best practices for crisis response services that are entwined with the developing 988 crisis lines. Workforce is a huge concern. We need better rates all around to pay our staff better. We need parity and your support in passing legislation on licensure exemption and bills that are presented currently in the Assembly and Senate by Senator Brooke and Brownson. We appreciate our partners in the State Senate and Assembly and look forward to working with giving these children the opportunity to heal and become healthy, functioning members of our community. I know with your support, we can come out of this stronger and more united than ever. Thank you.
Thank you so much, Janine. And I know you had to replace someone else, so I appreciate you coming and making sure that voice was heard. That concludes the panel. I will open it. If anyone has questions, they can raise their hand, or if Chairwoman Gunther has questions. I see Assembly Member Bronson. Go ahead.
Thank you, Senator Brooke. So this question is for you, Bill, and it's not going to surprise you at all. I'm going to talk about the licensure bill. You know, as I understand, I think you said you have a wait list of 1,000 people waiting for services. And, you know, what will happen if the licensure bill is not passed, that we don't allow mental health counselors, family therapists to diagnose and set up treatment plans? And Janine, this can be for you too. If we don't get that passed before the sunset, what's going to happen to your workforce, and explain why that's going to happen to your workforce relating to turnover, et cetera.
Great, thank you, Assembly Member. But there's two parts of this answer. On a going forward basis, what your bill does is creates parity between licensed mental health counselors and the other positions and social workers in terms of experience in learning how and being taught on how to diagnose and develop treatment plans. So now we'll have a broader system of experts and professionals in the field. But we've been operating under an exemption for the last 18 years or so. If that doesn't get extended, or better yet, fixed in your bill, we're going to have a whole cadre and a group of professionals that have no future, no career. And if they go to college at Syracuse or RIT or Marist, they won't be able to find a job in our profession because they won't be legally able to diagnose, which means you won't be able to bill insurance companies, and so agencies won't hire you. So our wait list of 1,000 people, I'll never be able to address. And then for the staff who are currently working for us, they're going to lose their ability to do their job, which means when you add in a 35% turnover rate to their current work, we're gonna tear down our system in the period of 18 months to 2 years. We'll reduce our mental health services to kids and adults by 50% within 2 years. In a time with, as Dr. Gill pointed out, there's a huge need. The universities have stepped up to increase the professionalization of mental health counselors and marriage and family therapists and psychoanalysts. The field is together on this point. I think we just need to come together if we're going to really meet mental health needs across New York. Otherwise, and I hate to be direct, the other conversation over the last 8 hours really won't have an impact. And we won't be able to hire licensed people for camps because they won't exist. And we're behind all the other states in the nation. I hate to say that. So your leadership on this bill is critical.
Thank you. And I don't know, Janine, if you want to weigh in, or if Dr. Gill or
Yes, I just wanted to add as well. I mean, obviously in the human services industry, mental health specifically, there's already a backlog, right? We're already having trouble recruiting new staffing, retaining our staffing and such. And so right now, you know, from a workforce and collaboration standpoint, I'll use Astor an example. We work very closely with a number of higher education institutions that at this point, we would have already had all our internships and already done outreach for new staff for those graduating. And now we've technically had to put everything on a pause. And so as Bill had mentioned, we already have a backlog. There's already a long wait list to see a mental health professional. And now as we enter into the summer and the beginning of the new school year, we're anticipating a jump in the need for mental health services. And so the bottleneck just becomes tighter and tighter in an effort to our ability, whether it be in person or telehealth. It's literally a capacity issue. And so by allowing these individuals, and based on the testimony, you know, the current workforce that we have really work interrelatedly, right? And so if you have mental counselors that are working with clients and then have to wait because they don't have the diagnosis, and then wait for the diagnosis to then come back, especially with the families that we work with, trust is a very big issue. So the more people you put into the situation, a lot easier it is to escalate the situation. And so we really want to be able to really increase our workforce and be able to expand it as much as possible.
Thank you.
Thank you, Janine. Thank you, Assemblymember Bronson. That is the conclusion of that panel. I want to give a moment if Chairwoman Gunther, if you have anything to add or ask this panel. But first, you got to unmute. Can't read your lips. You're still muted.
I'm sorry, I keep forgetting, you know, I'm an older woman. We forget these things, not really. But anyway, I mean, I think when we talk about the piece of legislation, it's stuck in higher ed, I think. That's what you're talking about. That Harry, and I know our new great senator, we can all talk to the chairperson and see if we can move it forward. I think that, you know, one of the things that annoys me the most in life is that when we see something that's solvable and, you know, we hesitate not to move forward, that, you know, it can't be the same old. We've got to change, and we have to change with the times. So, you know, I'm hopefully that the chairperson will move that bill forward to, you know, provide some assistance to all of you. And I thank you for your service, Dr. Rosa. You know, I mean, what a waiting list you have, honestly. You know, you're such a champion in this field. And on a sidebar, maybe you could give both the senator and I a call and see what we can do. Maybe if we get any grant money or something like that, Dr. Rosa, we might be able to help you, you know, because these children, you know, my son teaches on the Lower East Side in the Bronx. And my niece also teaches in Manhattan in one of the schools, and she works with special education. And, you know, so firsthand from my son, I get the gist. And this particular period of time, you know, my son was often supposed to be teaching, but there was a loneliness with these children. Their parents still had to go out to work, you know, affording a babysitter. There was nothing open due to COVID. And so we are going to look, they talk about a pandemic that we're going through right now. We're going to look at a different kind of pandemic with these children. And if we don't do something to enhance, get people to stay in the field, to do reimbursements the way they should in a camp situation where you've got a captive audience. It's such an important place. It's like a school, a camp where when we have a captive audience, this is when you can start the opening a dialect with a child that's suffering. It's just terrible. I think, and I don't care if I use bad language. Half the time we're in the New York State, we're ass backwards, and that's the truth. They really are. Yeah, I'm from the Bronx, Dr. Rosa. So, we in the Bronx, we say it like it is.
And in Rochester, we're
right. I will follow it with you, Assemblywoman and Senator. And thank you so much.
Thank you so much. And thanks all of you for what you're doing. I know this is, really hard times, as I said, being a nurse, and I've been volunteering in the hospital. I mean, it's just unbelievable. And there are no beds for mental health. There are our pediatric beds. And, that governor of ours, he closed beds this year. Can you imagine? He closed beds. And he tried to close the Rockland Psych Center, chill adolescent beds also. We were able, through the senator's help and working together, we were able to keep those 15 lousy beds open. But it goes from all the way from Sullivan County all the way down to down the pike to Rockland. That's the catchment area for 15 beds for adolescents. So there's a lot of work to be done. And I guess that, someone's got to shake something up and say, if we don't provide this service to children, of all things, that you're setting them up for being an adult with many, many difficulties, whereas the intervention at an early stage is just like what we do intervention with speech, with any child with a disability. And, it is a disability to have a mental health issue, and that we don't do the intervention, that we don't have social workers, the things that we need to be involved in these children's lives. And you know what? When you have poverty, you have two parents working that can't afford babysitting, it's just so difficult. My son taught in the Bronx, and you know what they're doing with children? They're sending an ambulance to a school district. Do you know what that does to a child? How upsetting it is? It's a horror show. And the fact of the matter is, we have to put more pressure on the governor and the leaders of both the Senate and the Assembly. And that's it. All right, they're probably going to fire me now.
Thank you, Chairwoman.
Do we have to send mobile crisis chair?
The thing is, we're going out fighting, right, Dr. Rosa?
Absolutely.
Great.
Thank you
so much to
Thank you, everyone. Thank you.
Thanks to all of you, and thanks for your patience. You waited a
No
long
problem.
time. Thank you to our senator, our wonderful senator that's really doing a great job, and we're so happy to have her. And of course, Harry, we love Harry. Who doesn't love Harry? Bye-bye.
Thank you for your leadership.
Thank you so much.
Bye.
Thank you. Thank you so much.